She's Bachcha, so we can see she's from Punjab.
Yes, yes, ma'am. Always.
Alok, you are from which place?
I'm from Delhi only, ma'am. Born and brought up here.
Okay.
But my parents, they are from UP.
Okay, which place?
Namaskar, Mehul.
Aligarh.
Ma'am.
We start
I worked
exactly
for
at
36 years in UP.
5, okay?
Yes.
Asha ma'am, I spoke to Dr. Gayatri Singh. She said she's fine with it. So
Okay.
we'll have to ask Dr. Mehul to shift the CVs on the CV deck.
Mehul, Dr.
Yeah.
Saida will go for the first talk as
Yeah.
chairperson. Okay?
Okay. No issue.
Instead of Dr. Gayatri.
Okay, we'll rearrange accordingly.
And so Gayatri ma'am will be in the second session. Okay.
So it's 5 and I think you can start.
ये तो कह रहा है लीव मीटिंग है, हमारा नहीं है.
Okay.
Ma'am, you are there. Please mute yourself when the program starts.
हमें नहीं तो इंट्रोड्यूस करना.
Mehul, you have to make me co-host.
Yeah, I'm going to do it. Okay. So good evening, all the delegates and faculties, and welcome for the Searchlight 14th Core Connect live webinar, which is on the updates on twin pregnancy. It is initiated by Cancer Prevention Relief Society in association with Dehradun, Dhanbad, Dhule, Dibrugarh, Dingidul, Durgapur, Bhimavaram, Faizabad, and Faridkot Obs and Gynae Society. So it's my privilege to welcome our convener, Dr. Sujayashree Sangeeta. Ma'am is a founder secretary of Bhimavaram Obs and Gynae Society, and she is consultant as Obs and laparoscopic surgeon at Seshadri Hospital. Ma'am has got numerous awards like Shan Ratnam Young Gynecologist Award as well as Foxy Dhira Award, and having the keen interest in laparoscopy and infertility. And ma'am is currently conducting awareness campaign also as the name of Vikasam for the adolescent girl. So I request to the Sujayashree ma'am, please proceed for the next.
Yeah. Thank you, Mr. Mehul, for that kind introduction. So I would like to take the honor to introduce Dr. Asha Jain, who's the medical director of SMSA Hospital, Raipur. She is also the medical director of CPRS, elected member of CG Medical Council, zonal chair, Foxy Food Drug and MSc Committee West Zone. She is also the chairman of Mission Pink Health, IMA Raipur, and executive member of ISCCP, CG ISAR, and CG SFM. Her previous posts have been, she's been the president of Raipur OB-GYN Society, vice president of IMA CG, and also the president of Rotary Club of Raipur North. Madam is an avid academician. She has received her certificate and she's also an instructor in FCCS. She has received her certificate of competence from the Gynec Academy. She's received training in colposcopy, and her fields of interest are saving the uterus, fetal medicine, critical care, and preventive oncology. I request ma'am to please take the program forward.
Thank you, Dr. Sujayashree, for that kind introduction. I would now request everyone to join in for blessings of the divine before we take the program forward.
वक्रतुण्ड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा.
असतो मा सद्गमय तमसो मा ज्योतिर्गमय मृत्युर्मामृतं गमय. ॐ शान्ति शान्ति
Asha, unmute yourself.
Ma'am, Asha, ma'am, please
Namaskar.
unmute yourself.
I welcome all the dignitaries to this 14th episode of Searchlight. This time, the Searchlight is on a dichorionic twin pregnancy. We have Dehradun, Dhanbad, Dhule, Dibrugarh, Dindigul, Durgapur, Faizabad, Faridkot societies, as well as Bhimavaram society, which is going to be our companion now. Our guest of honor are Dr. Sarveshwari ma'am, Dr. Amla Devi ma'am, and the chief guest is Professor P.K. Shekharan. The convener is Dr. Sujayshri. We have Dr. Alok Vashne, Joint Secretary, Delhi SFM, as our first speaker, with Dr. Saida Rizvi ma'am, Pranay Fukan, and Dr. Niladri Sen as our chairpersons. We also have Dr. Meenu Batra, a consultant from Simar, Kochi, as the second speaker, and Dr. Manisha Singh, Dr. Gayatri Singh, and Dr. Jatinder Kaur as our chairpersons. I will be moderating the panel on cases, and we have Dr. Jitendra Ghumare, Dr. Vishal Patil, Dr. Selva Rani, Dr. Dipanvita Sen, Dr. Radhika, Dr. Anshu Kakkar, Dr. Manjusha Pandey, and Dr. Jagjit Singh sir as our panelists. So I welcome everyone with folded hands, and I hope these 2 hours that you're going to spend with us will be actually very useful, and for all those who are experts will be a reminder, and everyone will take away a little something extra in their knowledge quotient from today's Searchlight. So I request Mehul, please share the CV of Shekharan sir. Professor P.K. Shekharan sir is somebody who's known to everybody in Foxy. He's the former professor and head department of Gynae, Government Medical College, Calicut, Kerala. He was the president of KFOG 2003 to 4, VP Foxy 2010, organizing chairperson of the 15th World Congress of GTD, secretary and treasurer, International Society for Study of GTD, co-author of FIGO Guidelines on Management of GTD, 51 publications with 407 citations. He has also served as captain in AMC with active participation in 1971 war. That is the war in which my father also participated, and Shekharan sir was a speaker at my first AICOG in 1989. I welcome you, sir. I'm really very honored to have you with us. We would like to have a few words of blessing from you for this program.
Thank you, Dr. Asha Jain, for these kind words. First of all, let me congratulate Dr. Asha Jain for organizing such a wonderful academic session, the 14th of which is going to be held today, along with so many other societies. The developments in medicine is so fast that none of us can really follow them without really spending time, which we don't have much of it. And this sort of CMEs and webinars will help us to pick up many things during this 1 hour or 2 hours that we spend along with our colleagues, sort of a combined learning program. And our colleagues, the president and secretaries of all the participation societies are there. We got our guest of honor, Dr. Amla Devi, as well as Dr. Sarveshwari Network. Welcome, madam, which is going to be a blessing with your presence, which we are all looking forward to be learning today. Twin pregnancies are more than double trouble. It is really very many things are there, and hopefully we are trying to cover a portion of it only. Actually, twin pregnancy, if you take, it will be a big chapter nowadays. It was not so earlier on when we were all students. Now the knowledge is so much that we know many of the problems which we can solve today, of course, with the help of the fetal medicine specialist. And the incidence of multiple pregnancies on the increase with availability of very effective inducing agents, ovulation inducing agents, as well as because of the ART procedures. So we are all eagerly waiting to listen to the respected speakers from various parts of our country. And I thank once again all of you for making me to be there with you for this wonderful program. Thank you, Dr. Asha, and congratulations for holding such a interesting programs and continuing.
Thank you so much, sir. You have done so much work on GDM. And if you're going to be here, you can give your inputs on the case of twins with GDM. If you are here, if you stay back. Thank you, sir.
Okay.
Thank you so
Thank
much.
you. Thank you.
May I have the CV of Amla ma'am? Okay, Sarveshwari ma'am. So, welcome, Dr. Sarveshwari Nautiyal ma'am. She is, when you meet her physically, she's a small, happy, very, very, like a bird. But she is so very focused on conducting screening programs and awareness camps. She has been the Director of Medical Health Services, Government of Uttar Pradesh, Director, Senior Consultant, and Colposcopist, RCC, TB Sapru Hospital, Allahabad, co-guide in MD, Superintendent in Chief at District Women's Hospital, Allahabad. There are so many accolades, but she is very focused on women's health, and also what I can say from personal experience is focused on the health of doctors as well. So she does a lot of early detection of breast cancer and cervical cancer camps, and also thyroid disorders camps. Welcome, ma'am. We would love to have your blessings.
Thank you, Asha. Searchlight. This is a beautiful name of this webinar. I know we are going to search many things, many people over here who are going to speak on the twin condition of the twin pregnancy, which was a very difficult case in our time. I just want to, first of all, I just want to thank all the speakers, all the panelists, and our chief guest, Dr. Sekharan and Dr. Amla. I really want to thank you all because you all are going to give something from your knowledge to the people attending this webinar. Asha has arranged and choose such a subject which is very important. I can share one of my experience of twins. I was posted in Gorakhpur, youngest doctor, and every time my senior, whenever there is a twin pregnancy, one delivered, one is not delivered, and a virgin is needed, so they used to call me. At that time, we were not having any technology to help us other than our hands. We just palpated, we just do it. This is twin, and we used to come to know after many times. Everybody of you who are worked in that time, and especially Dr. Sekharan, you will agree with me, our hands were so expert to find out what is going to be there. So I was very happy I'm called by my seniors. Then I asked one of my senior, why do you call me, ma'am? You could have done it. You are so experienced. She said, तेरे हाथ बहुत पतले हैं. Your hands are very thin. You can easily bring out the leg from inside, and we all are having our hands with a heavy weight. But it is not true. They were very experienced. I learned from them. Same way today, everybody, all youngsters are going to speak, and we are going to learn many things from them. One thing I want to state here, technology has brought a big change in our management. So diagnosis, managing, and management. I'm really owed to my anesthetists who encourage us to go for a painless delivery. They were giving epidural anesthesia. We were doing this. In that case, if there are twin delivery, it was very easy to manage. So Asha, you are doing such a good work. And you have chosen such a good speaker. I never wanted to lead this webinar, but I may go for a live CME at 6 o'clock or 6:30. Till then, I'm here. I just want to listen all of them. And one thing I want to give my best wishes to this webinar. This is a turning point in the management of the twin pregnancy. Here, I just want to mention one thing. I have met Asha many times in conferences, and I came to know she's a person who is full of knowledge. And I know she's going for an election. We can say election or a nomination. I can say I'm 100% sure you will win. My all good wishes, all blessings from Devbhumi Uttarakhand are with you. And I believe with the blessings of all the seniors, you are going to win and we are going to have a good chairperson in the Society of Food and Medicine, and that's all. Thank you so much. Thank you for giving me this opportunity to meet Dr. Sekran, Dr. Amla. Many of them, Alok, Minu, and so many, and my own Radhika Raturi and Manisha, and they are very nice. And Anshu Kakkar, they are doing a lot in Dehradun. I just follow them. Thank you so much, Asha. Thank you. All the best.
Thank you, madam. Thank you so much. Thank you. Mehul ji? So it is again a privilege to welcome Amla Devi ma'am, who is a very senior gynecologist. I spoke to her long back, 4-5 years back, and she has always been kind enough to accept any invitation that I may give her and always present. So she did her MBBS in 1965 from Tirunelveli. She joined medical services in 72, retired as joint director, project officer at DFW Chennai. She is the managing director of Annai Perimbam Hospital at Dindigul, founder secretary of Dindigul Obstetric Gynec Society, then the secretary. Currently, she is the president of Dindigul Society for the last 12 years. So, she's the president of Makkal Ottumai Media, Medai. I actually don't know what it means, but I would love to hear from her what it is. She has a lot of awards and honors. She's published books, and her fields of interest are adolescent health and women empowerment. Welcome, ma'am. Thank you for agreeing to be here, and we would love to have blessings from you.
Good evening to all who are participating in today's program. Regards and namaskars from Dindigul OB-GYN Society. Feeling proud and honored to be the guest of honor in the Searchlight 14th webinar. So my special thanks to Asha Jain, where she had only invited me for this program. My salutes to Dr. Shekaran, R.K. Shekaran, and then for my colleague, who is also this guest of honor and the convener. My best wishes and regards to everybody who is participating as speakers, chairpersons, and Asha Jain being she is the project director, Searchlight webinar, and moderator for today's panel, who had invited me for this program. So it is a focused series of topics of today's everyday relevance delivered by experts. Today's webinar will be focused on updates in twin pregnancy. When I was doing my PG in 1979, there was a case of twins. First one was a vertex I had delivered. I was a PG at that time. The midnight this has happened, and the assistant was sleeping in her duty room. Over enthusiasm and being a PG, I can do it with a confidence. Just I saw that the second one was a transverse lie. I just ruptured the membranes and I was delivered the baby. But I didn't put it in case sheet. But one of the assistant asked me, what did you do? I said, I did a podalic version. Why you have done it without taking into the theater? I said, the membranes fully, the cervix was fully dilated, membranes was bulging, the babies are small size. So I was able to do it. But nowadays, I think nobody will be allowed to do that, no, unless the seniors thing. That was lot of things we were able to do it in those days because of the government restrictions, as well as the more number of complications, more number of these twins occur due to the later age of marriage as well as ART. But my one simple and humble request is that this type of topics should be extended to the people and doctors as well as the paramedical people who are working in the rural areas and the periphery also, because in teaching institutions we will be learning more and more every day, but the complications actually the number is increasing, preterm delivery is also increasing, PROM is there. Due to that, the neonatal morbidity as well as the maternal morbidity and mortality is also increasing due to this type of twins. And there are 3 sessions. It's very lovely to see that first trimester, what is the evaluation you should do and how to advise. And then the second trimester, what is the evaluation and what is the counseling you should do for the patients. Once she becomes pregnant, it is a duty of the obstetrician to convince her that this is not lead to any complications. As soon as you follow the instructions of the gynecologist whom you are consulting. So all those things, you should become a counselor also nowadays, not only giving them medical care and all. So we can reduce the morbidity as well as mortality of the neonate as well as the mother. So this is a very, I think it is a very proud privilege to, and then the third thing is the most session will be on dichorionic twins. That is the panel on the third trimester pregnancy delivery as well as what is the labor and delivery will be evaluation. And these topics are nicely chosen, well planned, and the speakers are of very high quality. Speakers are there. So we would love to hear it till the end. I will be there till the end to hear, because from the youngsters, I used to say, when I got any complications, even today, I will call one of my junior and ask her what is the latest trend in the management of this complication. And we would love to hear from all those who are present here. And once again, my special thanks to Asha Jain, because calling from the law, they thing to the south end of this. So once again, I thank everyone who is present here to share their knowledge, because sharing of knowledge, dissemination of knowledge is a very vast thing and expected from all of the people. You contribute to the society by telling your experiences as well as about the discussions. So thank you once again to everybody.
Thank you so much, ma'am. That was very, very, very kind of you. And having my chief guest and guests of honor here till the end, there can be nothing greater than that. Today in the panel, we have not kept experts, and you are welcome as experts to give your opinion anytime, because there are 8 different cases and they are all different diagnoses. So I hope you will enjoy it and your time will be well spent. I thank all the chief guests, Dr. Shekharan sir, the guests of honor, Sarveshwari ma'am and Amla Devi ma'am, for this inaugural address. And with this, we will proceed to the scientific session. Request, Sujaya, would you please introduce our chairpersons?
Mr. Mehul, can you please share the slides?
Go
The
ahead.
chairperson for the first talk, we have Dr. Manisha Singh, who is the president of Dehradun Obstetrics and Gynecological Society. Welcome, ma'am, to today's session. Next, we have Dr. Saida Rizvi, ma'am, who is the president of the OB-GYN Society of Faizabad, Ayodhya. She is the senior most practicing gynecologist of Faizabad. She has worked in PMS services as a senior gynecologist, superintendent, and Madam has also been she's the present director of Pulse Hospital. She's conducted many CMEs. She's played an active role in detection of high-risk pregnancies. She's also been a recipient of Hospital Administration and Maintenance Award. She has received Family Planning Award, IMA Award. She's implemented a lot of programs. She's also actively taken part in Pulse Polio programs too. She's at present the president of the Faizabad chapter, and her field of interest is infertility. Ma'am, it's a great honor to have you with us today. Welcome to today's session, ma'am. Last but not the least, we have Dr. Jatinder Kaur, ma'am, who is the president of Faridakot Obstetrics and Gynecological Society. She's a senior consultant at Jas Hospital, Nangal. So welcome to today's session, ma'am. I request Dr. Saida, ma'am, to please introduce the speaker, Dr. Meenu Batra. Dr. Saida, ma'am.
No. The first speaker is Dr. Alok Vashne. Alok Vashne, sir.
Can you please change the slide, Mr. Mehul?
Actually,
speaker slide.
Dr. Pranay Fukan was supposed to be the chairperson in this session. He's
we
here.
Don't have the other two.
Yeah, sir is here.
I think there's been a little
Dr.
confusion.
Vashne sir's CV, please. Dr. Vashne sir's CV. Yeah. Dr. Pranay Fukan sir is the professor and HOD at Tinsukia Medical College, Assam. President of ISOPAP Dibrugarh since 2023. And he's trained in Boston, USA in infertility. He's kind enough to join most of our programs whenever he's called. Welcome, Pranay Fukan sir. And so for this session, we have Dr. Niladri Sen, who's the DGO DNB faculty, senior consultant of Durgapur Government Hospital, state trainer of CSEPA, president of Durgapur Society, and ex-secretary of Durgapur Society. So these are our Dr. Saida ma'am, Pranay sir, and Niladri Sen sir will be our chairpersons. And may I have the CV of Dr. Alok Vashne sir? Yeah. So over to you, chairpersons. Saida ma'am, would you please take this? Ma'am, you are muted. You are muted.
Ma'am, now you're audible. Yeah.
Can you hear me?
Yes, ma'am. Yes, ma'am.
First of all, let me thank Dr. Asha Jain for inviting me as a chairperson in this Searchlight webinar. The name itself is so brilliant and bright. There is brightness everywhere. I must introduce Dr. Alok Vashne, who is MBBS, who did his MBBS from New Delhi, UCMS, New Delhi in 1996, MD Radiology, Safdarganj Hospital, New Delhi 2000, and DNB also in Radiology in 2000. He is a Joint Secretary, Delhi State Chapter of Society of Fetal Medicines. He is editor of Newsteller, the Delhi State Chapter, production editor, and Journal of Fetal Medicine. He is a member of SFM National Executive, SFM Executive Academic Council in ultrasound practice for more than 20 years. He has keen interest in embryonic and fetal dysmorphology, Doppler imaging, and fetal echocardiography. He has presented so many papers and delivered lectures at various international and national and regional conferences. He has authored so many chapters in various textbooks of radiology and fetal medicine, and he is a co-editor Handbook of Fetal Cardiac Anomalies, SCF, SFM Karnataka, and he was awarded first prize for the poster Crossed Pulmonary Arteries at SFM International Virtual Conference in 2020. Dear friends, we want to have few drops from the knowledge, ocean of the knowledge of Dr. Vashne. To Dr. Vashne, over to Dr. Vashne, please.
Thank you so much for your kind words of introduction, Saida ma'am. And it's a privilege to be a part of this August gathering. And let me just share my screen. And I hope you can see the slides.
Yes, sir.
All right. So, and thanks, Dr. Asha, for inviting me to present this talk on twin pregnancy, the first trimester evaluation and advice. And we know these pictures, they look beautiful, they look very cute, the babies, but they are after they're born. So when they're inside the uterus, we are all the time worried because twin pregnancy, it is quite risky, as we know. There's a lot of complications which can occur during a twin pregnancy. And this is because that unlike the other species, for example, the dogs, they can have multiple pregnancies, but the primates, the chimpanzees, gorillas, and the humans, the evolution has occurred and the uterus is not designed to carry more than one passenger at a time. And which is why the foremost complication which we see with twin pregnancy is the preterm birth. And then because there are two of everything, then there are more malformations, more chromosomal abnormalities. And then of course there are complications which are due to a sharing of the placenta, the TTTS, TAP, STRAP, and selective fetal growth restriction. So coming to the first trimester ultrasound, patient may present at any gestational age for a scan. And it's our duty to identify whether it's a single pregnancy or a multiple pregnancy. Are the fetuses, they are normal, are they live, or if they are any abnormality. And what is very, very important is that we need to identify whether it's a dichorionic pregnancy or a monochorionic pregnancy. And this we can usually be able to accomplish when at 11 to 14 weeks of gestation. And at this gestational age, we also need to assess what's the risk for aneuploidy. Is there is a chance of developing a twin-to-twin transfusion syndrome or preeclampsia. Now, out of all the parameters that we measure, we assess the determination of chorionicity and amnionicity. That's the foremost importance. And that is because there is a marked difference in the stillbirth rate, in the perinatal morbidity for monochorionic twins compared to singleton, as well as with dichorionic twin pregnancy. So monochorionic twin pregnancy usually will have a 3 to 5 times higher stillbirth rate compared to a dichorionic twin pregnancy. So it is very important that right from the beginning, we need to identify whether this pregnancy is dichorionic or a monochorionic, whether the fetuses, they are sharing the placenta or they are not sharing, they have a separate placenta. And this is also important not only for risk assessment of perinatal morbidity and mortality, but this is going to touch every aspect of perinatal care when we are dealing with twins. So if we want to assess the genetic and structural malformation in a fetus, or if we want to offer invasive testing, we need to know the chorionicity and amnionicity. When we want to manage the discordant abnormalities, we offer selective feticide. We need to know whether it's a monochorionic or a dichorionic twin pregnancy. And the ultrasound assessment is the way we can identify whether it's a monochorionic or dichorionic pregnancy, and this is most accurately assessed in the first trimester. So if less than 10 weeks, it is actually very easy. The number of gestational sac corresponds to the chorionicity of the pregnancy. And the number of the yolk sac, it corresponds to the amnionicity. There can be some rare exceptions, but by and large, this holds quite true. So when we see an image such as this in the first trimester, early part of the pregnancy, we are seeing 2 gestational sacs. We know we are going to have a dichorionic twin pregnancy. And in my opinion, out of all the examinations, ultrasound examination we are going to do throughout the gestation in this pregnancy, this is the most important image of all. When I see this image, when there's a confusion later on at 20 weeks, 30 weeks, I can go back to this image and see, yes, there were 2 gestational sacs. It's a dichorionic pregnancy. It's not a monochorionic pregnancy. So it is, if you're doing your scan, if an obstetrician is doing a scan, if an infertility specialist is doing the first scan, always document that there are 2 gestational sac or a single gestational sac. Very, very important. And of course, then as the pregnancy progresses, we will see 2 fetuses in their 2 gestational sacs. They will be surrounded by their own separate amniotic sacs all around them. In monochorionic twin pregnancy, there is 1 gestational sac, which is going to give rise to 1 placenta. So typically, we can see sometimes a single gestational sac with 2 yolk sacs, or single gestational sac will have a single yolk sac. So this is virtually, you cannot distinguish that this is a singleton pregnancy or a monochorionic monoamniotic pregnancy. But the chances of a monochorionic monoamniotic pregnancy, they are anyways quite very, very, very low. But if we wait a little, we call the patient back, and at 7, 8 weeks, 9 weeks, we can see that there are 2 fetuses inside a single gestational sac. Here also we see there are 2 embryos inside a single gestational sac. But here the difference is that these fetuses, these are enclosed in their own separate amniotic cavities, whereas here the same amniotic sac is harboring the 2 embryos inside. So this is a typical monochorionic diamniotic twin pregnancy, and this is a typical monochorionic monoamniotic twin pregnancy. Now, according to guidelines, the best time for assessment is at 11 to 14 weeks of gestation. And if we see 2 placentas, we know that these are going to be dichorionic twins. There can be minor exceptions. But when we see a single placenta, we need to look at this intertwin membrane, the membrane which is separating the 2 twins, whether it is present or absent, how its base appears, and what is the thickness of this membrane. So with dichorionic twins with fused placenta, we see this twin peak or lambda sign, which is nothing but insinuation of the placental tissue in between the membranes, and this gives us a triangular appearance, which is known as the twin peak or a lambda sign. This is a sign of dichorionic twin pregnancy. Very important to see in the first trimester itself, because at that gestational age, it is 100% accurate, can identify the dichorionic twins. But as the pregnancy advances, this twin peak sign is going to get lost. And later on at 20 weeks or later on, we are not going to see these sign in many of the pregnancies, and then we'll be confused whether it's a monochorionic pregnancy or a dichorionic pregnancy. And the intertwin membrane is generally more than, the thickness is more than 2 millimeters in dichorionic pregnancies. In monochorionic pregnancy, we see the insertion of the membrane directly onto the placenta. There is no lambda sign here. There's no triangular projection of the placenta at the base. And it appears like a T. So this is known as the T sign. This is a sign of monochorionic diamniotic twin pregnancy. And the intertwin membrane is very, very thin. The thickness is less than 2 millimeters. And then we can have a monoamniotic twins. So in monoamniotic twins, we are not able to identify the intertwin membrane at all. So what we need to do is we need to do a transvaginal ultrasound. In these cases, we need to make sure that there is no intertwin membrane. And when we find the fetal parts, they are intertwined, and we see entangled umbilical cords, then of course we are going to diagnose that these are monoamniotic twins. These are not dichorionic or a monochorionic diamniotic twin pregnancy. So these are monoamniotic twins. Now coming to dating of twin pregnancy. So again, the best period to date them is from 11 to 13 weeks, 6 days at the time of the NT scan, when the CRL is 45 millimeters to 84 millimeters. The important thing to note is that whenever there's a discrepancy between the crown rump length of the two fetuses, we need to use the larger of the two CRLs for dating. Because if we use the smaller of the CRL for dating, then we may think that the smaller fetus is the normal fetus and the other fetus is growing maybe a bit too much. But uh, in actuality, it is the smaller fetus that is predisposed to a fetal growth restriction. So we need to always see the larger CRL as the one which for dating. And when there's an IVF conception, then of course we can use the embryonic age from the fertilization, and that can give us the correct period of date. Structural abnormality is very, very important in twin pregnancies, and especially in monochorionic twin pregnancies, the incidence of abnormalities is 2 to 3 times higher, and we see a lot of CNS, cardiac abnormalities, GI defects, facial lifts, and clubfoot. Discordant anomalies are the anomalies that affect only one of the twins, and this incidence is also very, very high in monochorionic twin pregnancy. So the upshot is that we need to check both the fetuses very, very diligently for major abnormalities at 11 to 14 weeks of gestation. Very important at 11 to 14 weeks of gestation, because if we wait for the anomaly scan in the second trimester, sometimes these patients, they are obese. Sometimes we are not able to assess these abnormalities so well as we can do in the first trimester by preferably by using a transvaginal sonography. And these are some of the abnormalities which are always detectable in the first trimester. So anencephaly, inencephaly, lobar holoprosencephaly, or body stalk abnormality, a large omphalocele gastroschisis, megacystis, and limb reduction defects. These are abnormalities which we must be able to identify in the first trimester itself. And then sometimes we can also identify other abnormalities such as a cleft lip palate or an open neural tube defect, as we can see here, a single umbilical artery. This is a case of a twin pregnancy showing polydactyly at 11 weeks of gestation. Why polydactyly is important in this case? Because this case, the patient, they wanted to have a selective termination of one of the twins. And of course, when a polydactyly was discovered in one twin, this twin was the one which was reduced. And then there can be complex congenital malformations of the heart. So this is a case of hypoplastic left heart syndrome. We are seeing the left heart is very, very small. It is not showing any color flow inside. And there is a reversal of flow in the aortic arch. A case like this can be very, very easy to miss in the first trimester. So this is at 12 weeks, 6 days. One of the fetus, it is showing a small and bent femur, whereas the other fetus has a normal femur. So it is very important that we need to assess every fetal part very diligently in the first trimester at the time of anti-scan for looking for congenital malformations. Now, aneuploidy screening in twins, it's a little bit complicated. Like in singleton pregnancy, the test of choice for aneuploidy screening is the combined test, which is the double marker test with combined with the nuchal translucency. But the type of twinning, it influences how we are going to calculate risk. So if there are dichorionic twins, we can calculate the risk per fetus. So each fetus can have its own individual risks. So if the NT is higher, the risk is also going to be high. If the NT is low, the risk is also going to be low. Whereas in monochorionic twin pregnancy, the risk is calculated for the pregnancy as a whole and as entirety. So what we need to do is we need to combine the NTs of both the twins and then take an average and use that for calculation of the risk in monochorionic twin pregnancy. So sometimes this overall risk, this is going to reduce even if one of the twin is having a high NT. Now, fortunately, the combined test performs similarly as in a singleton pregnancy. It's just a minor variation, but by and large, we can do combined test in the first trimester in twins as well. But there are some conditions in which the combined test is not recommended, and major one of this is the vanished twin with a measurable fetal pole. So we see one twin and we see another twin which is dead, and we are seeing the measurable fetal pole. In such a scenario, we are not going to offer the combined test. We are going to calculate the risk by using maternal age and NT, because when we are seeing this fetal pole here, this is going to skew the measurements of beta HCG and PAPA, and we are not going to get a proper risk calculation. Now coming to NIPT, yes, we know it is a better test than a combined test because it has a very high detection rate and a very low false positive rate. But it can be applied in twin pregnancies very, very easily. But we need to know that the detection rate of NIPT for trisomy 21 is slightly lower for twins than in the singleton pregnancy, and the data is very, very limited. But in general, there is going to be some cases in which the trisomy 21 may get missed on NIPT in twin pregnancy. And again, NIPT, it should not be performed whenever there's a visible pool of a demised twin, because the DNA from the demised twin, that is also going to skew the measurements. So invasive prenatal testing in twins. So we need to offer this test very carefully in twin pregnancies because the invasive testing, it carries much, much greater risk in twins compared to singleton pregnancy. There's a very high loss rate compared to singleton pregnancy. And as a general rule, we want to do CVS in dichorionic twin pregnancy because we need to make diagnosis of abnormalities of aneuploidy genetic syndromes as early as possible so that we can offer earlier selective termination of pregnancy. But in CVS for dichorionic twins, we need to sample both the placentas. And in monochorionic twin pregnancy, we generally perform amniocentesis because if we do a CBS from the common placenta of a monochorionic twin pregnancy, we can miss discordant chromosomal abnormalities of a monochorionic twin pair. What about selective feticide? So we have detected abnormalities on the ultrasound or in genetics. Then for a dichorionic twin pregnancy, it's pretty straightforward. We can do an ultrasound-guided intracardiac or umbilical vein injection of KCl or lignocaine. And this should be preferably done in the first trimester itself, because if we wait till the second trimester, there's a higher risk of miscarriage and preterm birth. But for monochorionic twin pregnancy, we cannot do this injection of potassium chloride because when the one baby is going to die, the other baby is also going to suffer. So for monochorionic twin pregnancy, we prefer cord occlusion or intrafetal laser ablation or radiofrequency ablation. But these are things which are done only in the second trimester and not in the first trimester. Now, preeclampsia screening. So we are very, very comfortable doing preeclampsia screening in singleton pregnancies at the time of NT scan. But in singleton pregnancies, the risk factors, they are very, very well established. The prediction model works very well. And we have the intervention. We can start the low dose aspirin, and we know that this reduces the rate of preeclampsia by 62%. But in twin pregnancy, first of all, the twin pregnancy itself is a very, very important risk factor for preeclampsia. And almost 10% of the twin pregnancies, they are going to develop preeclampsia, but the risk factors, they are not well established. And the benefit of aspirin for prevention in preeclampsia is not very clear in twin pregnancy. So there is, we can do this first trimester screening for preeclampsia in twins by using the same protocol that we use for singleton pregnancy, but with some minor modification. So we do not use PAPA, we use PLGF instead. But even after using such a risk calculation, this prediction model, it underperforms and there is a high false positive rate. So more or less at the time of NT scan, this preeclampsia risk screening, it is not very helpful in case of twins. And similarly, the biggest problem with twins is preterm delivery, but first trimester assessment of cervical length, that is not going to be very helpful for risk calculation of the preterm birth. This cervical length measurement, it has to be done only in the second trimester. But when we do a transvaginal ultrasound in a twin pregnancy, sometimes we can pick up this kind of abnormality. So this vessel, this umbilical vessel, this is inserting at the internal os. This is vasa previa. So the chances of vascular abnormalities like a filamentous cord or a vasa previa, they are much higher in twin pregnancy. Now, the last segment is about the complication in monochorionic twin pregnancy. The most dreaded complication is the twin-to-twin transfusion syndrome, which affects
Excuse me,
mostly.
sir. Alok, sir.
Yes, ma'am.
Monochorionic we are going to take in the next webinar.
Monochorionic
So,
next?
In the next webinar. So
Okay.
I was just requesting you to give a very brief outline and then to tell what to advise the patient.
All right. So basically, this is all is left. See, the topic which I was given was twin pregnancy. It did not mention dichorionic actually. Anyways,
First trimester, sir, that's fine.
Yeah. So these are basically markers for the first trimester monochorionic twin pregnancy abnormalities. So anyways, doesn't matter. So we know that the twin pregnancy, it is going to be a
Sir,
high risk.
le lijye, go back and take it.
As you wish, ma'am.
Yeah.
So in twin-to-twin transfusion syndrome, we do not have, there are some signs which we can use for prediction of TTTS. So if we find increased NT in one of the twins, or abnormal flow in the ductus venosus, or CRL discordance, or amniotic fluid discordance, this may be an indicative of TTTS, which is going to develop later on. And anyways, these fetuses, they will require surveillance from 16 weeks onwards. Twin reversed arterial perfusion, it is possible to detect many such cases in the first trimester itself. We see a malformed fetus which is drawing its blood supply from the healthy fetus, and this is putting the healthy fetus at risk. So we can identify this very, very early. So whenever we see even a seemingly dead embryo with a twin pregnancy, it is very, very important that we put on the color Doppler and we find out that it does not have any vascularity inside, because if we are seeing a vascularity, that means there's a twin reversed arterial perfusion in these cases. Cord entanglement, very, very common. It is universal in monochorionic, monoamniotic twin pregnancy. It is not associated with complications of fetal death. So we should not be unduly alarming such patients when the report reads there's an entanglement of the umbilical cord. Then conjoined twins, complication of a monochorionic, monoamniotic twin pregnancy. We should be able to identify these fetuses at 11 to 14 weeks of gestation. And in fact, in my practice, we generally identify them at the embryonic stage. So this is a thoracomphallopagus twin, and this is a dicephalous conjoined twin. We see a single body with two heads, single umbilical cord. So these are complications which are unique to monoamniotic twin pregnancy. When to suspect conjoined twins? If these fetuses, they lie very close to each other and they assume a parallel head-to-head position, then we need to see that there's a distance, there's a gap between the two fetuses. Because whenever we see there are two fetuses, the first question the patient is going to ask, are these conjoined twins or not? So make sure that these are not conjoined twins. So we know this is a high-risk pregnancy. It requires specialist care. And if somebody is not comfortable dealing with a twin pregnancy, it's best to refer to specialists who can handle a twin pregnancy. Out of all the parameters, we need to determine what is the chorionicity and amnionicity, and this should be done as early as possible. The monochorionic twins pregnancy, they are at much higher risk for complications, and they need to be followed up very, very often. and Dr. Meenu is going to cover that. Morphological assessment for for aneuploidy screening, this should be done at 11 to 14 weeks of gestation. And the pre-eclampsia screening and screening for preterm birth, these are not effective for twin pregnancy. And that's all. Thank you so much.
Thank you, Dr. Vashni. Thank you so much for giving such a informative and juicy lecture in such a short span of time. You have covered all the things and you have showed the figures also. It was really amazing. Can I ask you one question?
Yes, ma'am, please.
At what stage we can detect anencephaly in a twin?
So at the time of 11 to 14 weeks, it is very easy to detect anencephaly. But
all the anomalies.
Anencephaly, yes, it can be detected because at that gestational age, the skull bones, they are ossified. And if we see the head shape in anencephaly, it is going to appear very irregular, whereas the normal head is, rounded shape. But in my practice, let me tell you, I diagnose generally anencephaly at 8 weeks.
At 8 weeks?
Yes.
That's what I want to know.
Dr. Pranay, sir?
Doctor?
Pranay Fukan, sir? Pranay, sir? Alok, sir, there is one question for you.
Yes, ma'am.
Somebody has asked on YouTube that when you are measuring the NT and the CRL, do we have to measure them individually or not? And whether to take the average or the individual one? And which one is to be taken as standard? You've answered that, but actually they want to know that again.
So the nuchal translucency is measured for each fetus. And we have to take the standard plane in which we are measuring the NT. For dichorionic twin pregnancy, for risk calculation, we are going to use them separately for risk calculation. So if the NT is high, the risk is going to be high. If NT is low, the risk is going to be low. But for a monochorionic pregnancy, we are going to use both the NTs and we are going to add them and then divide them by 2. That means we are taking an average NT. And then we are going to combine them with the serum biomarkers, and then we are going to arrive at as a risk for the pregnancy as a whole.
Thank you, sir. Thank you, sir, for that clarification, and also to take the CRL of the bigger twin.
Yes, the CRL, yes, we are going to use the CRL for bigger twin for calculating the gestational age.
Thank you, sir. Thank you so much. Pranay, sir, you want to say something? He has disappeared again. Means he's there, but I cannot see him. So I think we proceed to the second lecture. The chairpersons have already been introduced. So I would request
Dr.
Gayatri ma'am.
Yeah, we haven't introduced Dr. Gayatri Singh.
Yeah.
Yeah. So
go ahead.
Madam is a senior consultant at Dr. Jyotir Bhushan Institute of Medical Sciences in Jharkhand. Ma'am has completed her MBBS and DGO from Patna Medical College Hospital. She's presently working as a senior consultant at Dr. Jyotir Bhushan Institute of Medical Sciences, and she's a present president of Dhanbad Obstetrics and Gynecological Society. She's been the past secretary of the same, and she's an ex-CMO of the Central Hospital, Dhanbad. And her special interests have been adolescent health, high-risk pregnancy, gynec and endoscopic surgery. Dr. Gayatri Singh, ma'am, I would please request you to introduce the speaker, Dr. Meenu Batra. Dr. Gayatri Singh, ma'am.
Ma'am, you're muted. Gayatri,
you're
ma'am, you're
muted.
muted.
Could you please unmute yourself?
Hello, am I audible?
Yeah, now you're audible, ma'am, please.
Yes, at the outset, I would like to give thanks to all the organizers, Dr. Asha Jain, ma'am, our this program director, our convener, and my regards to all the chief guests and the guest of honors, and all of you. I would like to give thanks for giving me this opportunity. Now, I would like to introduce our esteemed speaker, Dr. Meenu Batra. She is a teaching faculty, FBN High Risk Pregnancy and Perinatology Fellowship Training Program at CIMAR, teaching faculty at PG Training Program at SRMC Chennai, RE Focus Trichur. Her areas of interest: obstetric ultrasound, prenatal diagnosis and therapy, and genetics, fetal genetics. Her notable achievements: she has been awarded Ashok Mukherjee Reward at AOCR 2018 Mumbai for the best paper retrospective analysis of outcome of intrauterine transfusion done for fetal anemia, a single center experience. She has also presented paper at the World Congress on USG in Obstetrics and Gynecology 2013, Sydney, Australia, and 2019, Berlin, Germany. She is a secretary, Society of Fetal Medicine, and as well as executive committee member. She has been committee member, IFUMB. She is the vice president. She has been the vice president Kerala chapter of SFM. Her publications are various publications in national and international journals, and her presentations are faculty at various national and international conferences. So you are such a learned, so much of important positions and achievements you have, ma'am. Dr. Meenu, ma'am, I am really very lucky to introduce you, and I am welcome you, and I would like to invite you for your talk. Please,
Thank you.
over to Dr. Meenu.
Thank you so much, ma'am. I'll just share my screen.
Hello.
Your screen is visible. You need to make it full screen.
Yeah, just a second. Yeah, is my screen visible, a slideshow?
Yes. Yes, Dr.
Yeah.
Meenu.
Yes. Thank you, ma'am. Thank you so much for the opportunity, Asha ma'am. And I think at the start of my talk, like Dr. Alok, I will have to say a disclaimer that I also have prepared the talk as a brief outline of what you are going to see or how do you monitor complications both in dichorionic and monochorionic. As you have mentioned, I will try to keep monochorionic as brief as possible. So starting with the presentation today, as Shekharan sir rightly pointed in his uh, speech that today, yes, twins are on the rise because we have mothers who are getting pregnant at an advanced maternal age. And because of that, they end up undergoing various types of ART treatment, because of which we have a higher incidence of twins. And as Alok rightly mentioned, it is the a sign of happiness for the parents when they come to know that they are carrying a twin pregnancy. But as a clinician or as an imaging specialist, it is a nightmare for all of us, because we know that these are high risk pregnancies, different from your normal singleton pregnancies, and need to be given those extra care. So in the next 20 minutes or so, what I am going to do is chart out a basic outline, because I understand that this webinar is primarily being attended by clinicians who are general practitioners. And we know that twins need to be attended separately, which has been rightly done today by Asha ma'am, because there is a prenatal burden that is involved, especially of prematurity. So going back to the basics first, we know that when the separation of the morula happens within the first 4 days of gestation, we end up getting what is called a dichorionic pregnancy. But if the splitting happens later on, that is within the first 7 days, we get something called as monochorionic diamniotic pregnancies. And when the splitting happens after 7 days, we get what is called as a monochorionic monoamniotic pregnancy, the delayed splitting of which further can sometimes lead to conjoint twinning. So we all are aware of this basic, and we have studied this right from our MBBS days. Now, what is also important for us to understand as clinicians is that on ultrasound, it is only the chorionicity that we can judge. We cannot give you any information as far as the zygosity is concerned. So why I'm saying this is because we have to understand that even when you see a dichorionic pregnancy on scan, around 30% of them can be monozygotic. However, most of the times when you see a dichorionic, it is a dizygotic pregnancy essentially. Now, of course, when you see a monochorionic pregnancy, you will see a single placenta with two separate amniotic sacs. And when you have a monochorionic monoamniotic pregnancy, as Alok rightly mentioned, you will have two pregnancies within the single sac without any intervening membrane, and you also see a single placenta. So, as was mentioned by him, there are two important things that you're trying to do. You're trying to look at the chorionicity and the screening. In fact, chorionicity is the foundation which is going to decide as to how, as clinicians, you are going to follow up these pregnancies. The most important message that we should probably be taking from this session today is that we should defer using the term, or as a clinician, if you get a report which tells you twin gestation corresponding to so and so weeks, that report actually goes into the waste bin. Because unless and until you do not have the chorionicity mentioned on the report, you will not know as clinician how frequently I need to call my patients back for an ultrasound and other clinical follow-ups. So chorionicity is the most important thing that you need to know. And it is also important to know that because we know that in monochorionic pregnancies, you have vascular anastomosis, you have sharing, and the imbalance between this vascular anastomosis can sometimes lead to increased incidence of complications in monochorionic pregnancies as compared to dichorionic pregnancies. So, as in the first trimester, as mentioned, you will see the lambda sign and you know that this is the dichorionic pregnancy. And when you see the T sign at the interface of the membrane and the placenta, we know that this is a monochorionic pregnancy. Now, this sign is very beautifully seen when you do your 11 to 14 week scan. But as the gestational age progresses, that is, as and when you go into the second trimester, now, even though today we do talk about picking up abnormalities early, doing scans early, you still have instances where the patient lands up to you for the first time with a twin pregnancy and you send her for a scan. So now the dilemma that comes up is how do you assess the chorionicity of this pregnancy in the second trimester? So then what you do is rather than just looking at the lambda and the T sign, you try to look at the number of placental masses. So like here, you can see sometimes a good lambda sign in dichorionic pregnancies, but sometimes you will not be able to appreciate it that well. So you look at the placenta implantation. So we know that if the placenta is implanted at two different places, you have an anterior placenta in one of the fetuses, a posterior in another one, you know that this is essentially a dichorionic pregnancy. And also you can look for a discordant fetal sex, which is commonly seen in a dichorionic pregnancy. Monochorionic pregnancies are generally same gender fetuses. Now, even after seeing all this, if you still are not able to make out the chorionicity, the best thing here that we can do is in second trimester, if you're not certain about the chorionicity, please classify them as monochorionics and monitor them as a monochorionic pregnancy rather than just being overconfident and leaving them unmonitored. The second important thing that you have to know is labeling of twins. Now, most of the times what happens is the patient will get scanned from an A center at 12 weeks and lands up at a B center for 16 weeks and goes to the third center at 20 weeks. So what happens is what was fetus A for the person who did the scan first probably becomes fetus B for the person who scans second. And the third time she goes, again, the fetus B becomes fetus A. Accurate labeling of twin gestations is very important because you want to measure this growth of the baby in the serial scans accurately, and then only you can understand how is the growth trajectory of that particular fetus. Also, in conditions where you want to do an invasive test, say an amnio, you want to label the twins correctly because, and you also want to sample the correct twin. Also, in cases when you have one of the twins with growth restriction or a structural abnormality, you want to pass on this communication correctly to the neonatologist who is going to conduct the delivery. So labeling of twins is very, very important on ultrasound. And usually what we do is we hold the transducer longitudinally, and depending on the orientation of the membrane, the fetus that is closer to the membrane, the cervix, is what is labeled as fetus A, and the fetus away is what is labeled as fetus B. So now, as far as the routine monitoring of twins, twins is concerned, when it comes to uncomplicated dichorionic twins, you need to see them once every month. And when it comes to uncomplicated monochorionic twins, you have to see them once every 2 weeks. So for dichorionic twins, after your 12-week scan, you will see them for a fetal well-being scan at 16 weeks. And then you call them for a 20-week scan where you will look at their anomaly, you will look at the growth of the baby, you will assess the liquor, and you will also look at the cervical length. Now, if all this is normal, we know that this is an uncomplicated dichorionic pregnancy. These pregnancies can be followed up on a monthly basis where you can routinely look at their fetal growth, the Doppler, and the Liker volume. So this is the flow chart which we all can follow when it comes to monitoring of an uncomplicated dichorionic twin pregnancy. Whereas when you come to monochorionic pregnancies, after they have had a 12-week scan, the next visit is going to be at 16 weeks. And from 16 weeks onwards, you are going to follow them at 2 weekly intervals. Again, at 16 weeks, you do a fetal growth assessment along with their Dopplers, which includes the DV and the umbilical artery. At 20 weeks, you will do an anomaly screening, a growth assessment, fluid assessment, and cervical length assessment. And then every 2 weeks, you will call them for Doppler surveillance. And if the growths are okay, the growth measurements can be done on a monthly basis. But every 2 weeks, you have to do Dopplers uncomplicated pregnancies where a monthly follow-up is enough. In monochorionic pregnancies, essentially throughout the pregnancies, they are going to be under a fortnightly surveillance. Now, in your anomaly screening scan, just as how we do for singletons, we are going to perform it between 19 to 22 weeks. Now, it is very important that as clinicians, when you're sending your patient for the scan, you have to counsel them that the anomaly scan is going to take at least 45 minutes. For the imaging specialist to complete the scan, it will take at least 45 minutes, considering the fact that both of the babies have been nice enough to us to change their positions and show each and every structure. We definitely understand that the risk of anomalies is higher in twins as compared to singletons. Especially in monochorionic twins, there is an increased incidence of abnormalities related to the brain and the heart. Now, what do you do when you have an abnormality that is picked up in the second trimester? We do talk about, again, I would repeat, we do talk about early detection of structural abnormalities, but still it is very common that you pick up abnormality in one of the twins. Now, in dichorionic twins, you would end up picking up a structural abnormality in one of the twins. And we know that the chance that the other twin may also get affected is very less, because in dichorionic twins, it is two different embryos which have actually got implanted. So it is basically two different people living in their two separate 1 BHK flats. But in monochorionic, what happens is we know that there is splitting of the embryo into two. So there are two people who are sharing the same flat, the same environment, the same genetic potential. So essentially, monochorionic twins will have the same genetic makeup, and usually structural abnormalities will also affect them in the same way. But there is exception to this. Sometimes you can have something called as heterokaryotypic twins and anomalies that are related to when the process of splitting happens, such as the anterior abdominal wall defects or abnormalities related to the heart, can sometimes affect only one twin in a monochorionic pregnancy. So when you have an anomaly detected, you have two options. First option is you manage them routinely, and second option is that of selective termination. So I will give you two different scenarios here. This was a patient, dichorionic diamniotic pregnancy. I have marked the lambda sign in red, and you can see I have shown one fetus here where you can see both the heart and the stomach are seen at the same plane, which means both of them are seen in the thorax. So one of the fetus was having a congenital diaphragmatic hernia. This was detected at 25 weeks of gestation and was continued as such. The other baby, because the amount of lung was compromised, did not survive, and she delivered after birth. The other baby died, and she continued with the single baby. But there was another second case where one of the baby had anencephaly in a dichorionic diamniotic gestation. As you can see in this case, this was detected at 18 weeks. Now, in this patient, what we did was a selective fetal reduction by injecting potassium chloride. Now, somebody would have a question here that a second trimester reduction, A, has got a higher loss rate. B, why was it done for anencephaly when it is a lethal anomaly? We all know that anencephalic fetuses are not going to survive anyways. So why am I putting my patient, or why should I put my patient through this risk of selective fetal reduction? Now, we all need to understand here is that even though anencephaly is a lethal abnormality, what happens is the swallowing center is absent in these fetuses. So eventually, these fetuses will develop polyhydramnios, which poses a threat of preterm labor to the normal fetus as well. So in these kind of scenarios, where even though the anomaly is lethal, but it poses a threat to the normal twin also, selective fetal reduction can be offered. Now, in dichorionic twins, the procedure is slightly simpler because all you need to do is inject potassium chloride directly into the heart, as you have seen in this video. But in monochorionic pregnancies, it is a little more complicated. If you have to do a selective fetal reduction, your options include intrafetal laser ablation, cord occlusion, or radiofrequency ablation. Now, I'm not going into the details of this, but what you will choose will depend on the kind of discordant anomaly that you are seeing and the gestational age at which you are going to see it. Another important thing that we have to do when you do a anomaly screening scan is to assess the cervical length. And mind you, whenever the cervical length is being assessed, it has to be done on an empty bladder using a transvaginal scan. Transabdominal scanning should not be used for assessing the cervical length, and the cutoff is usually 25 millimeters at 18 to 24 weeks of gestation. Now, this is said to be a moderate predictor of preterm birth, less than 34 weeks of gestation. And even though the positive predictive value is low in asymptomatic women, this is the only way we can screen these patients for cervical length. Another important thing that we are worried about now, how do you know whether a twin pregnancy is complicated or not? One we talked about was structural abnormalities. Now we would talk about growth discordance. So when do you say that there is IUGR in one of the twins? When you find that the estimated fetal weight of one of the twins is less than the 10th percentile, or you find that the inter-twin estimated fetal weight discordance in the scan report is more than 25%. Now, when you find that and the Dopplers are normal, these fetuses now will be put under growth surveillance fortnightly rather than every monthly, as we said earlier, for uncomplicated dichorionic twins. So the easiest way, even if you do not remember these numbers, is to look at the growth charts. To assess growth, the most easier way that you can assess the growth of a fetus or even in twin pregnancy is to look at their growth charts. So anybody who would look at it would, at this growth chart, would understand that you look at the growth chart of fetus A, it is following the growth trajectory, which is the blue line. But if you look at the green line, which is the growth trajectory of fetus B, it is falling down. So looking at the growth trajectory itself, I know that one of the fetuses is going into growth restriction. But in dichorionic twins, whenever you pick up growth restriction, the next question that comes as a clinician in your mind is, now how frequently should I send her for scan? How am I supposed to monitor? So in dichorionic twins, things are comparatively simpler because all you need to do is you need to put them on Doppler surveillance based on your protocol and the FGR staging that you follow for singleton pregnancies. I am not going into the detail of the FGR staging in singleton pregnancies, but the monitoring would be same. And the second decision dilemma that you get is, when do I decide to deliver this pregnancy? Because suddenly at 26 weeks, you tell them one baby is not growing well. And the patient comes to you and tells that, aisa karo, dono ko hi nikal lo. No, we should not do it at that point of time, because at 26 weeks, if you do it, you are also putting the normal growing twin at the risk of preterm delivery, prolonged NICU stay, and associated complications. So what should be your cutoff? Your cutoff to make that decision is 32 weeks. Now, if till 32 weeks you find that the growth restricted fetus is also having essentially normal Dopplers, you can decide, take a delivery decision after 32 weeks to save both. Because we know that after 32 weeks, we are going to get good outcomes for essentially both of the fetuses. But if before 32 weeks you have severe early onset IUGR with severe Doppler changes in the smaller fetus, we should always defer to make a delivery decision, because you're also going to pose the threat to the normal fetus as well. And whenever you see pictures like this, do not worry, because even though here you see in this case, look at the growth trajectory of fetus A, which is in blue, it has been going down, but their Dopplers were essentially normal. And therefore, if you look at this particular chart, we were able to take this pregnancy up to 34 weeks of gestation. And even though there was a discordance in the growth velocities, both the babies are today doing fine. In dichorionic twins, you will always see a growth trajectory difference. So for you to understand that, if you look at line green and line B, they are apart. You see the line blue, which is the growth of fetus A, is actually below the 5th centile. That is below the lowest line. But as long as both of them are following their own growth trajectory, we are not worried about growth restriction. These are two different people living in two different rooms with two different environments. But as long as they're able to follow their growth trajectory, we are not worried. As opposed to this case, we know that there is a fall in trajectory, and therefore we need to follow them up and keep them under close surveillance. And therefore, depending on the stage of IUGR that you follow in singletons, you will increase the frequency of surveillance. Now, in monochorionic twins, in monochorionic twins, also you can have selective IUGR, which is basically because of discordant placental territories. So the baby that has got a smaller placenta is going to be smaller, and the baby that has got a larger sharing is going to be growing well. So you will see a picture like this. You will get a scan report. There is estimated fetal weight discordance. And then you start thinking whether this growth restriction in one twin is TTTS or it is selective IUGR. So the most important point that you look there is the Leiker discordance. In TTTS, you will always have a polyoligous sequence along with growth restriction, whereas in selective IUGR, you will have growth restriction with normal Leiker and reduced Leiker. There will be no poly. And selective IUGR, depending on the umbilical artery change, is classified into 3 different types. And depending on the type, you will decide on the surveillance, which I will not be discussing today. Now, the options, sometimes when you have selective IUGR, your choices are you can either do an expectant management, just follow them up, or you might have to offer them intervention in the form of cord occlusion on laser. Now, the choice of that will depend on the severity. So if you find that the selective IUGR is really severe, has happened very early, that is less than 24 weeks, the discordance is too much, less than 35%, more than 35%, and you have severe Doppler changes. So there you can discuss these options of fetal interventions with the patient and take a call as per the patient's decision. Now, briefly talking about, I would just touch upon these complications of monochorionic in the second trimester. We talk about twin-to-twin transfusion syndrome, TAPS, and selective IUGR, which I have already discussed. Now, in twin-to-twin transfusion, what you would see is, so as a clinician, basically in monochorionic twins, one thing that we can remember, we raise the alarm bell if you find 3 things. You find in the report that there is a discordance in the Leiker. That is, you see polyoligo. You raise the alarm bell if you find a discordance in their AC. That is, the estimated fetal weight discordance is more than 25%. Or if you find that one of the fetuses is having a velamentous cord insertion. So then you have to, again, increase the frequency of surveillance, because you want to rule out complications like twin-to-twin transfusion syndromes, which can happen in 10 to 15% of monochorionic pregnancies. So the first alarm bell is raised when you see polyhydramnios in the recipient, when you have a deep vertical pocket of more than 8 at less than 20 weeks and more than 10 centimeter at more than 20 weeks. And you see oligohydramnios, that is stuck twin. So your scan will show a picture like this. You see the intertwin membrane? No. But what you see is head of one fetus, and you see the other fetus technically floating inside a lot of fluid. Now, if you try to look in detail, you would be able to see the membrane. And then when you look at the Dopplers, you sometimes found Doppler changes as well. And if you see Doppler changes, we know that this is stage 3. Sometimes they come to you as late as in stage 4, where you can see that in the recipient fetuses, you can also have high drops. So depending on your Quintero staging, it can be classified. But what we need to understand is once you have detected TTTS, you need to refer them to a fetal medicine center, because they are the ones who are going to decide when a fetoscopic laser coagulation is required. Because if that is not done, there is 100% mortality with cases of TTTS. Now, the next complication, the third complication that you're worried in the second trimester is a single IUFT of one of the twins. Now, when it happens in dichorionic twins, we are essentially not worried. The only risk that probably as clinicians we all worry about is whether there is any increased risk of DIC. But what we have seen is that it is more of a theoretical risk, and usually they continue well as singleton pregnancies, even if there is an early or late IUFT in a dichorionic pregnancy. But again, the problem is when it happens in a monochorionic pregnancy, because then there is 15% chance of death of the co-twin or neurological morbidity in the co-twin as well. So in those cases, sometimes what can happen is after the death of the co-twin, the other normal twin can develop neurological changes like this, which tell you that there is an increased chance of neurological impairment. But whenever you have a single IUFT in monochorionic twins, please do not go for a preterm delivery, because if there is any damage that has to happen, it has happened at the time of that IUFT. So you need to keep them on follow-up, keep on looking at their MCA PSV to rule out fetal anemia, do a fetal neurosonogram after documentation of the co-twin death, after 4 to 6 weeks of documentation of the co-twin death, and you can also suggest an MRI after 4 to 6 weeks. The last complication that we need to be worried, which in monochorionics, which happens usually in the late second trimester or the third trimester, is twin anemia polycythemia sequence. It is similar to TTTS in the sense that it happens because of the unbalanced AV anastomosis, but these AV anastomoses are really small, and therefore it presents as an anemia polycythemia sequence when in one twin, the MCA PSV mom is less than the 0.8 mom, and in the anemic fetuses, you find that it is more than 1.5 mom for the gestational age. So you would see a picture like this where the two placentas look completely different. One looks very bright and the other one looks very dark. The MCA peak systolic velocities are two ends of the moms, and you also see that there is a difference in the appearance of the liver. So in these cases, the management is always controversial. Usually you only need serial surveillance. How much transfusion helps? We really don't know, because when you're trying to do for the anemic fetuses, you're also increasing the hemoglobin of the polycythemic fetus as well. So to conclude, in nutshell, what we all need to remember is for dichorionic twins, the first scan is at 12 weeks, follow-up scans at monthly intervals, fortnightly surveillance after 30 weeks of gestation, and you deliver them at around 36 weeks. For uncomplicated monochorionic pregnancies, you call them for a scan at 12 weeks, followed by 16 weeks, and then fortnightly surveillance with ultrasound and Dopplers, and they are also delivered at 36 weeks of gestation. Now, at each gestation, when you see them at 12 weeks, important points are in your report, you should have accurate dating, accurate labeling, accurate chorionicity, and the screening markers for trisomy 21 need to be assessed, which includes your NT and other markers. When you get your follow-up scans at monthly intervals, you do a fetal well-being scan. In your anomaly scan, you will rule out anomalies. And in fortnightly surveillance, you again look at the growth, Leica, and Dopplers and deliver them at 36 to 37 weeks. The same protocol also works for your monochorionic twins, where in essential, you will also do Dopplers every time they come for a surveillance to pick out complications that are related to vascular imbalance. So first trimester, chorionicity and predictors of TTTS, in particular for monochorionic. Second trimester, in DCDA, you look for selective IUGR. In monochorionics, you look for vascular complications. In third trimester, you will again look for late onset IUGR or any late IUFDs. And in the monochorionic twins, you will look for specific complications like twin anemia polycythemia sequence. Thank you.
Thank you so much, Dr. Meenu. You
Thank you,
really
ma'am.
tried to put everything in.
Ma'am, as Alok said, actually, when I understood the message as evaluation of twins in the second trimester. So
yeah,
I think,
it is evaluation of twins. Actually, it is in the third trimester where you need special attention to dichorionic and a special attention to monochorionic. So we will be taking that in the next time. First and second trimester, everything is common, no issues. So Dr. Gayatri ma'am, you are muted, please. Gayatri ma'am, you are muted.
Am I audible?
Yes, ma'am.
Thank you, Dr. Meenu, for your nice, lucid presentation. Earlier,
you,
we
ma'am.
were having no choice of only expectant treatment, and what we could have we have been taught about masterly inactivity. Now there are so much advancements in the field of genetics and in the radiology. Due to you people, we are now able to catch each and every little things, and we can predict the outcome of the pregnancy in twin pregnancies, and we can accurately give the EDD to the patients, so we can terminate in monochorionic or dichorionic diamniotic, how when to deliver her, when everything will be normal. So it is all very well. You people, it's a very good thing. Nice. Thank you for the fetal medicines and you, Dr. Meenu. It's very nice, very good, and further we can treat accordingly to your presentation. You have done very well, very nice presentation, very clear presentation. Thank you.
Thank you, ma'am.
For your paper.
Thank you so much. Dr. Meenu, would you please stop sharing? Dr. Shekharan sir, Amla ma'am, Dr. Sarveshwari ma'am, if you want to say something about the two lectures, you're welcome, and then we will start with the panel.
You can sit down to it. Listen to everything, very well done. Both the speakers have given a lot of information and which is very useful to all the clinicians on day-to-day practice and what exactly you have to do at what time. And for the scanning as per the chronicity also is been mentioned. And unless you follow them like that, we may land up in problems. So it is to be known when to send the patient, how often they have to send. So very clearly mentioned by both the speakers, and we should carry on with this sort of a management to reduce the complications and also the litigations, because sometimes the TTTS may be missed and you may not be able to save the baby. So these are all salvageable complications. So we should know basically what to do. Thank you, Dr. Meenu, and very well presented. Thank you.
Thank you, sir. Amla ma'am, would you like to add something?
Excellent presentation. I think nothing more to add to a talk. Actually, everybody should keep it in mind that is the monochorionic is more dangerous than the risk is more with monochorionic than the dichorionic. So if you keep it in how to do the scans and follow techniques, everything, if you keep it in mind, the complications will be less and the patients also can be convinced by this thing. Thank you.
Thank you, ma'am. Thank you, ma'am. Dr. Meenu and Alok sir, are you going to stay around or you want to log out?
Ma'am, I'll be joining from my phone actually. I'll be staying in, but I'll be logging out from this computer and joining from my phone.
Yeah, means the reason I'm asking is supposing we need any help, are you people available there?
Yes, ma'am. I will be there.
At the end, if there is any questions for you, no, I think you can answer, no?
Yes,
because
Alok sir? Alok sir?
I'm working at my clinic, so I'll be listening to everything.
Yeah.
I mean, if needed, you can help out, right?
Yes, please.
Yes,
Thank you,
same here.
Thank you.
So I'll be working, but yes, I'll be available.
Thank you. Thank you so much.
Thank you, ma'am.
So now we start the panel. Thank you, everyone. We have run really late this time. So, but it was a great discussion and the topics that were covered were really great. So we start with, at the outset, I would like to request all of you to support my nomination for Food, Drug and Medico-Surgical Equipment Committee. The nominations will come in May. Please do support me. Now we have the panel and we will be introducing the panelists along with their questions. Before I start the program, this is a chart that Dr. Meenu has shown, the other part of it. This is dichorionic twins, antenatal visits, and ultrasound assessment. So when to do, what to do, when it is needed, and when to deliver. So this is a basic chart that is present. Less than 10 weeks, you need to do the antenatal booking, gestation, first trimester scan, then 16 weeks, 20 weeks, when to do Dopplers. So this is a very big takeaway. And about the intrapartum care, 60% of twin pregnancies have spontaneous birth before 37 weeks. All should be cared in the delivery suite. Mode of delivery, vaginal delivery in labor ward if twin 1 is cephalic, cesarean section if both twins or one twin, the presenting twin are non-cephalic, and cesarean section if monochorionic, monoamniotic twins. So this is the norm. For women who aim to have a vaginal delivery, you need a continuous CPG for both twins. Delivery should be in a place where you can take for cesarean immediately if needed. Anesthetist and neonatology should be there for delivery. Delivery of twin 2 should not be rushed if there is no cord prolapse or bleeding and the fetal heart remains normal. But the interval should be less than 30 minutes. Twin 2 may need stabilization of lie, internal podalic version, breech extraction, or immediate cesarean section. And also we need an active management of the third stage. So this is the basis. Now, our panelists are Dr. Jitendra Ghumare sir, who's the president of Dhule Obstetric Gynec Society, and Dr. Vishal Ramesh Patil, an MBBS DGO from Government Medical College Dhule, DNB 2008 from Godavari Hospital Jalgaon, Senior Registrar Galaxy Hospital Pune with Dr. Shailesh Dambekar, and District Nodal Officer of Maharogi Shivir Dhule 2018, Joint Secretary IMA Dhule previously, Treasurer, Joint Secretary of Obstetric Gynec Society, currently Secretary of Dhule Society. Welcome, sir.
Thank you, madam.
Sir, please put on your video and you can unmute yourself.
Yes,
So
ma'am.
the
Thank you.
first
Thank you very
case-
much.
Thank you, sir. So, sir, we have the first case of growth discordance, which is the most common thing, and we are only dealing with dichorionic twins right now. So, Mrs. S is 32 years old, dichorionic, diamniotic twin pregnancy, and she's at 32 weeks already. Now, the ultrasound shows growth discordance, twin A at 75th percentile and twin B at 10th. So what is the potential cause of growth discordance in twin pregnancies?
Hello.
Yes, sir. Vishal,
Yes,
sir.
ma'am. Potential causes, maybe twin to twin transfusion is there. Growth.
Sir, this is a dichorionic twin pregnancy.
Yeah.
So
Hello.
there is less space in the uterus.
Yeah, there is placental cause, maybe. Hello.
Yes, sir. Yes, sir.
I'm Dr. Gumre, madam.
Yes, sir.
The common cause is placental because the space is occupied. Placenta is big. So I think for this patient, it is placental insufficiency.
Okay. Or it could be constitutional, could it not? One baby is big, one small, as Dr. Meenu just showed, that they are
Yes.
both growing parallelly.
Need to follow the both graph.
Yes. So how often are you going to do an ultrasound? In a dichorionic pregnancy, how often is an ultrasound advised for growth?
Once in month, madam.
Yes, sir. Once in 4 weeks.
Yeah.
And when are you going to decide delivery? She's 32 weeks now. So when do you plan to deliver her? What are the end points where you would like to deliver her?
If Doppler is normal, we can wait. But ideally, as Minu Batra madam said, 32 weeks is more than enough. We can proceed with option of delivery also.
More than
No,
32.
sir. No, sir.
34
This is a dichorionic pregnancy. You have to
Madam,
carry till 37 weeks.
yes, madam. Yes. If
So,
anything abnormal
Bhumre sir,
on top. Yes, madam, we can carry up to 37 weeks, and if anything found abnormal on Doppler or something significant, then only after 34 weeks we can think of termination.
sir, so the basic thing is we have to do Dopplers, we have to do the umbilical artery, and we also have to do the ductus venosus.
Yes.
And the ductus venosus is the cutoff. If there is
Yes.
any problem in ductus venosus, you're going to deliver the baby, but otherwise you're going to wait. You're going to
Yeah.
wait till the Dopplers become abnormal. You follow the growth trajectory. Here, you do the Dopplers every 2 weeks, if needed, every week. Okay. And
Yes.
the growth scan once in 3 weeks. So, when will you deliver her? If the Dopplers get abnormal,
Yes.
or if there is any other obstetric indication, she gets PIH or anything. So, what are the maternal and fetal surveillance measures that we have? How will you
NST,
monitor this baby?
NST, madam.
NST.
Both NST. You need to put 2 probes.
Yes, madam.
So we will do NST and
Doppler, biophysical profile.
agreed. Doppler will have to be done every 2 weeks. Okay. And if there is growth discordance, one baby is now 1.5 kg, the other baby is 2.9 kg. This is just an example. How will that impact your mode of delivery? You want to deliver normally or you want to do a cesarean section? You have carried her to 37 weeks. Would you like to do normal or vaginal delivery or you want to do a cesarean delivery?
If there is a hello.
Yes, sir.
Hello. If there is any obstetric indication for cesarean section.
No, sir.
Or
Here the question is, one baby is small. It is 1.5 kg. One
Okay.
baby is 2.9 kg. So
If the
do you want to do normal or you want to do cesarean?
Doppler is normal, then we can go for vaginal trial. If both babies are vertex.
Dr. Vishal, would you like to say something?
I will take for cesarean.
Actually, अपनी practice में आप क्या करोगे? Let us
Cesarean
speak of
section.
that. You would do a cesarean section,
Yeah.
right? And anybody else wants to add something? Anybody present here who has a different opinion? Because we have one person saying vaginal, one person saying cesarean. So what is the consensus? What are you going to do?
I think a cesarean, ma'am, definitely.
Cesarean is better for the.
Exactly. Because if the baby is small, you cannot use an instrument to deliver it. The pressure on the fetal head is going to create a problem, especially if it is the second fetus, right? So, what are the potential complications during labor and delivery in dichorionic twin pregnancies with growth discordance? What problems could you have in labor and what could happen?
Most probably malpresentation, TPH.
Malpresentation, yes. And
At the time of delivery, PPH.
Cord prolapse may be there.
Cord prolapse.
Cord prolapse.
yes. And
Chances of meconium stain.
Fetal
Meconium
distress.
fetal
You could
distress.
get fetal distress. You could get fetal distress. We don't actually do scalp electrode monitoring. But
Yes, ma'am.
here, what is important is that during delivery, both babies should have the CTG on. That is the biggest thing. That if you are going to try for vaginal delivery, you want to have a CTG on both babies. If you want to do a cesarean section, then you cannot use an instrument on the head of the smaller twin. And then you have to guard for, the placental position. You have to guard for PPH. In this case, is there anything anybody wants to add? Anybody here who wants to add something? Yes, Radhika?
Ma'am, am I audible?
Yes, yes.
Ma'am, I think we'll just have to keep the theater also ready so that in case of any emergency, the shifting procedure should not take much more time. One thing
See,
in mind.
that we have decided that she has to deliver near the theater.
Yeah. And
with anesthetist and OT person present. Okay, but how many are actually going to try her for normal delivery?
No, not with the medical legal scenario today. I don't think so.
Okay. Okay.
I think that would be my first fear rather than anything else, considering the litigations.
So, when the size is different, you are going to see whether it is a growth restriction or it's a small for date. So you have to see the biometry. Less than 3% automatically makes it FGR. If it is more than 3%, up to more than 10%, with any other problem, then it is FGR, not otherwise, with Doppler changes. Okay. So when such a baby comes, you have to first thing is make out whether it is a growth restriction or it is a small for date, because they are two different babies. It's a dichorionic pregnancy. And then accordingly, they have to be managed. Dr. Selvarani.
Yeah, ma'am, I just want.
Yes.
I'm Dr. Meenu this side. I just
want
to
go
add
ahead.
one thing. See, when I said that the cutoff is 32 weeks, it is basically a cutoff that you use when you want to salvage both the twins with one of the fetus having FGR. So if you have a severe Doppler abnormality, you use 32 weeks as a cutoff. But if you just have FGR in stage 1, say only the umbilical artery is showing resistance,
no,
then we can keep on monitoring.
You have normal Dopplers right now.
So yeah, normal Dopplers, then you can put them on a fortnightly surveillance. And as you said, we can deliver them till 37 to 37 weeks. I just wanted to clarify the 32 weeks cutoff that I said is for the twins where one of the twin is FGR with a severe Doppler abnormality and the patient wish is to salvage both the twins. Therein you can use 32 weeks as a cutoff to take your delivery decision earlier. Yeah.
Okay. Thank you. Thank you for pitching in. We have Dr. Selvarani Jayaraman, who's the secretary of Dindigul Society, and we have Dr. Deepanvita Sen, who's a senior consultant at Durgapur. She's the secretary of Durgapur Society. Madam has joined in.
Hello, ma'am.
Yeah, Deepanvita, welcome.
Yes, ma'am. Thank you, ma'am. Thanks for the opportunity, ma'am.
Thank you. So you have preterm premature rupture of membranes. So she is Mrs. J, 30 years old, DCDA twin pregnancy at 30 weeks. She presents with a history of PPROM in one twin, but intact membranes in the other. So one twin, the liquor has drained off and the other liquor is still there. So I start with the basics. How are you going to confirm that this is PPROM?
Clinical, can I?
Yeah, please go ahead.
Clinical history of ruptured membranes, then speculum examination, a sterile speculum examination to see if there is liquor draining. These are the two most common ones. If there is no LICA draining, then we can go for an ultrasound scan to look at the LICA volumes on both the twins. The biochemical markers are not easily available, so they are more theoretical at this stage, at least where we belong. And that is about confirmation, ma'am. And if we cannot see any LICA, we can do the pad test check for the a clean dry pad. We ask the patient to wear and then look at hold the pad and see if there is actually leaking going on.
Okay, so now here you have already seen that one twin has lost its LICA and the other twin, the LICA is intact.
Yes,
so what are your major concerns?
So the concerns are infection, concerns are premature labor, preterm delivery, and these babies are 30 weekers, so their brain maturity, their lung maturity are still to happen, and mainly infection and premature delivery, ma'am.
So, when we have a singleton pregnancy and it has a premature rupture, then what do you say? That you don't really want to prolong it till except the steroid cover, right? So here, what do you want to do? You want to prolong it further, or you want to take the other baby out?
No, we would
Which
definitely...
baby are you actually going to consider?
We'll take out the first baby and we'll switch on the, we'll take expectant management for the second baby. With the steroids.
How will you take out the first baby? The cervix is not dilated or anything. It's just that the membranes have ruptured for one baby and there is no LICA in one baby. And the other baby, everything is normal and it's dichorionic. It's not a monochorionic pregnancy. So they have two separate placentas. So what are you going to do here?
Expectant management first, ma'am. First, ensure both the babies are having normal heartbeat and normal CTGs. If mother is not infected, there is no fever, there is no maternal tachycardia, there is no uterine contractions, no uterine tenderness, and the LICA is clear in color and the LICA is not smelly, which means she has no evidence of chorioamnionitis at this point in time, my management would be expectant management, ma'am. And expectant management would involve...
Till which age?
As long as they can carry on. I mean, 34 is the first target, and then up to 37 weeks, in fact, we can carry on if the babies remain well.
Now, what are the considerations for timing and mode of delivery? If the mother develops any infection.
If the mother develops any infection, the baby should be delivered whenever we suspect the infection or the infection is proven. We have to deliver then and there. This is 30-weeker. We should, at the admission, we should administer the steroids, the corticosteroids, administer magnesium sulfate. She is just 30 weeks on the brink of the gestation where we would consider the magnesium sulfate for fetal brain maturity. We should discourage tocolysis, keep the babies and the mother on surveillance. So 3 people have to be on surveillance. And at any point we find there is any compromise, maternal infection or fetal CTG becoming abnormal, or the Dopplers becoming abnormal, we should deliver in an institute where there is an ICU facility available.
Means what are the potential maternal and neonatal complications? Supposing she has come to you at 30 weeks. Now she is 32 weeks. It's already been 2 weeks. So what are the potential maternal and neonatal complications associated with prolonged duration of PPROM?
So infection is the most common.
Yes. And
chorionitis and PPH also.
And pressure on the pressure of the uterine wall because of lack of LICA, the lung maturity I mean, lung maturity, solid lungs are more common if the PROM happens before 20 weeks.
Actually, so you have two babies at two different conditions.
Yes, ma'am. Yes,
one baby without liquor, one baby absolutely normal. Right. So whom are you going to consider?
The baby who is not at risk, those with intact membrane, we will consider for that baby.
Okay, Dr. Meenu? Dr. Meenu? Would you like to take us out of this problem? She's not listening. Dr. Alok, sir? Alok, sir? See, when I was doing my fetal medicine, what my consultant said to me was that everything depends on the neonatal services that you have. Because the baby without liquor, if you carry it too long, it has a great chance of being lost. You may lose that baby may not survive once it comes out. Okay? Or it may die inside itself. So one fetal demise is there, then you're going to look after the other baby. Because as Dr. Meenu showed you, there's only a 3% chance of the other twin being affected. Okay. So you follow the other twin because that is the twin that you are really going to get good. If the patient comes immediately, either you have one decision to make, and again, counseling and talking to the patient is very important. What she and her family decide. Because they may not really be ready to spend so much at the NICU. Looking after a premature baby for 2 months also is very expensive. So one part is the counseling part. The other part is if you are going to lose one baby, then it is better to take out the other baby when it is more healthy. So you carry it as much as you can, but you have to remember, counsel, and take written consent that the baby who has had PPROM may not survive. And then you have to guard for chorioamnionitis. That is very, very important. So, anyone else has anything to add here?
Proper counseling.
Any different opinion?
So, ma'am, probably on balance, 1 week if we get, the babies would get the benefit of the steroids as well as the magnesium sulfate.
See, if once you give steroid, the baby has to come out in 48 hours. 7 days. You give steroid when the baby has to come out in 7 days. Otherwise, you hold the steroid. So, when the patient comes at 30 weeks and you have done the ultrasound, you've done the Dopplers, that is when you need to have a detailed counseling session with the family. Right?
Yes.
So, you have to examine this. You've already done. Following the diagnosis of premature rupture of membranes, antibiotic has to be given. 24 to 33 weeks gestation, give steroids. Clinical assessment, maternal blood test, CRP and white blood cell count and fetal heart rate should be used to diagnose. If you plan her to deliver, only then you give steroid and magnesium sulfate. So that is the guideline. Now, we have Dr. Anshu Kakkar and Dr. Manjusha Pandey, who's the secretary of Faizabad, and Dr. Anshu Kakkar, who is the secretary of Dehradun Obstetric Gynec Society. So, we also have Dr. Radhika Raturi. I've made some mistake in the CVs. Dr. Radhika, forgive me. The immediate past secretary of Dehradun Obstetric Gynec Society. So this case is gestational diabetes. Shekharan sir is here and he's an expert. So Mrs. M, 34 years old, DCDA twin pregnancy, she is 36 weeks. She has been diagnosed with GDM and is struggling to maintain glycemic control. So how does GDM impact fetal growth and well-being in DCDA twins? And how do you monitor that in the third trimester?
I'll say sorry for my bad voice because I'm down with viral.
Thank you for being here.
GDM, on the contrary, in singleton pregnancies, we see a lot of macrosomia, but it is the exact opposite in a DCDA twin, that we'll probably expect more of small gestational age babies. So therefore, we are more stringent in a singleton pregnancy for control of diabetes, but a little more liberal when it comes to twins, so that we do not face this complication of sudden hypoglycemia causing SGA babies. So we usually keep the percentile of the blood sugar till about, say, 120 in a diabetic mother with twins. And in case of we've discussed the scanning, that in a normal uncomplicated DCDA twin, it will be a first trimester scan, a second trimester scan, after 20 weeks 4-weekly scan, and after 32 weeks it will be a bi-weekly scan. And it may differ depending in between if the case has any complexities.
So what is your cutoff for sugar? This level is the 120 that you said, that is that the average blood glucose, or it is the postprandial, or is it the 1 hour postprandial?
It's the average blood glucose that we consider. This is what I think.
It's 95 milligram per DL or more than 95. We are considering fasting.
For twins, ma'am, lot of studies say that we can use 120 as a cutoff because हमें बिल्कुल euglycemia में नहीं लाना है. So some papers said 95.
It is not average. It is not average.
Fasting.
Okay. So in singleton pregnancy, you take 110 as the PP cutoff. Here you would, it can go up to 136 also. Okay. But it is not the average. Shekharan sir, would you like to say something?
No, whether it is twins or singleton, we have to have the proper control of diabetes, especially not that very times Madam was saying, but it is important to have control of diabetes. And the fasting may be kept between 90 to 100 and for 2 hours, maybe 120, 126. So she may not go in for hypoglycemia as such, as we are stating. We can have a control and continue with the pregnancy, so that if otherwise we may not be able to carry on with the pregnancy to a decided maturity. So control the diabetes as it is, and don't.
So thank you, sir.
Allow the first blood sugar
to go down. Yes, sir. So are you going to give her insulin?
Ma'am, depending if she's on oral hypoglycemics and if they are not.
No, she is not. She is GDM, right? She has just been diagnosed. So are you going to give her insulin? She's 36 weeks.
36. We would like to wait till 37 because it's an uncomplicated DCDA. So we can consider giving her insulin in case we buy time for a week. That will have better controls. Otherwise.
Okay. So if she has GDM, is your monitoring any different than the normal DCDA?
No.
So does GDM influence timing and mode of delivery?
Yes, yes. GDM definitely GDM.
Ma'am, usually the worst control is 32 to 35 weeks. They say between 36 and 37, sometimes the levels may, normalize on their own.
What I'm saying is, if she has GDM, does that change your opinion about the mode of delivery or the timing of delivery? When do you plan to deliver her if she has diabetes with twins?
If she hasn't spontaneously gone into labor, then 37 weeks.
Okay. And what are the potential neonatal complications with GDM?
respiratory distress, hypocalcemia, hypomagnesemia, hypobilirubinemia, and transient tachypnea. Sometimes these are possible complications that one can have.
You forgot the one that is most important. That is hypoglycemia. See, the baby is used to so much sugar that once it comes out, hypoglycemia is the most common, and everything else comes from that.
Forward, yes, I agree.
Okay, thanks a lot for that. But the whole point of this case is that the management of GDM is as per GDM, and the management of twins is as per twins. So there isn't really much of a difference.
So can we give her insulin? I mean, coming back to your question.
Yes.
Right?
You should give her insulin because she's already 36 weeks. And actually, my saying yes is not right because we don't know what her baseline sugar is. If her fasting is 170, you're going to give her insulin. If it is just 105, then
we will not.
Maybe you want dietary control.
Right.
So that would depend, like any non-pregnant patient, basically. Or singleton pregnancy, any pregnancy, depending on what levels she is getting. Now, if she has an HbS/Ag of 10, then you're going to give her insulin definitely, but you don't want sugar to come down drastically because that causes fetal hypoglycemia and intrauterine fetal death, which we want to avoid. So this is it, gestational diabetes. So if fasting more than 125, 2 hours more than 199, it's diabetes. You give 75 grams of OGTT 4 to 12 weeks postpartum follow-up, and then manage. If there is increased weight you want to lose, fasting less than 100, 2 hours less than 140, she's normal. So you have to follow up postpartum these patients as well. Okay? So private practitioner at GR Hospital, Dehradun.
You don't need to say it. We can go on.
Thank you so much, dear. Now we have Jagjit Singh, sir, who's the secretary of Haridkor Obstetric Gynec Society, and Dr. Manjusha Pandey, whom I introduced before. So Jagjit sir was here. Yes, sir. Welcome, sir.
Thank you, Asha ma'am. I'm really overwhelmed by your energy. Yesterday we were together in another webinar, and today again you are up and running like anything. If without being an office bearer, you are working so much. What wonders you will do to Foxy when you'll be elected as a chairperson. My best wishes to you, ma'am.
Thank you, sir.
And my
Thank you,
special namaskaran to Dr. P. K. Shekharan, a very good friend of mine. Vanakkam, sir, vanakkam. And yes, let's continue.
Thank you.
And let's continue with the our panel.
Yeah, thank you.
So now, sir, Jagjit Singh, sir,
yes,
Mrs. W, 29 years old, DCDA twin, 34 weeks. She comes with sudden onset abdominal pain and vaginal bleeding. So my first question is, what could it be? What is the DD that comes to your mind?
Obviously, at the sudden current any vaginal bleeding with abdominal pain, first of all, we always suspect it to be a placental abruption.
Okay.
And because in placenta previa, there is no pain. And ruling out other surgical condition, if she is suffering from any surgical condition which has abdominal pain, that may co-present with the placenta previa and bleeding. Clinically, you have to overrule such condition. Otherwise, it's very common to get at this age, this gestational age, because placental abruption is a serious complication, and other indication causes of bleeding can be any uterine scar disruption, because that also comes with pain, and there is bleeding also associated. So these are the things which come into my mind. But if there's no
Sir,
pain,
why for dichorionic twin pregnancy, why is placental abruption more likely?
Because while diachronic twins still have two separate placenta, they share the same uterine environment, which means they are not immune to risk of placental abruption. There are several factors which also contribute, which are maternal, fetal, and placental factors. They also contribute to this condition.
Yes.
These more space is occupied, and so that could be the reason over here.
So how are you going to monitor this patient, sir? How are you going to confirm your diagnosis?
As far as confirming this diagnosis is concerned, again, we because placental abruption mostly comes up with the fetal distress also. So we need to work on those parameters also. The
So would you do an ultrasound? And would you see
definitely
anything on the ultrasound?
that will be only the any fetal distress can only be monitored with ultrasound only. Otherwise,
Sir, can you see an abruption on ultrasound? A fresh abruption on ultrasound, can it be seen?
Definitely color Doppler will help us most of the time when there is even when there is no bleeding and there is only concealed bleeding. That also happens, and ultrasound will only help us to delineate that.
Okay. Most of the time, it is very difficult to see immediate bleeding because it goes subchorionically and it's very, very difficult to see. So it is our clinical sense more than anything else, and the tenderness of the uterus that guides us. So if you have seen that she has placental abruption, now what are the indications for urgent delivery? When do you think you want to deliver her fast?
When there is along with placental abruption, when there are signs of any coagulopathy or there is preterm premature rupture of membrane, uh, there is fetal distress, there is fetal malpresentation, and in these conditions we will go for early delivery and urgent delivery.
So she is 34 weeks. So do you think she needs steroid? And if she has, see, most of the time abruption can be associated with TIH. So are you going to give her steroid and wait or not?
I don't think there is any point in waiting for a twin at 34 weeks. Because already she has got complication, and the fetus is not going to survive in abruption for much of the time. And even if steroids are given, you don't have much time to wait.
Okay, so you're going to do a cesarean and take out the babies.
Baby, yes, ma'am.
Yes, sir. So what are the complications that you expect? You know, she is a case of APH, and now you are taking out the babies. So what is the complication that you expect?
Definitely, like in singleton pregnancy, the most common complication I'll be wary of is hemorrhage, because if it results in significant maternal bleeding, it can lead to hemorrhagic shock also. And second factor, because of any massive bleeding, I'll be looking for any DIC, because placental abruption can trigger the coagulation abnormality. And intrapartum, there can be uterine atony also because of severe bleeding and hemorrhage, and which can lead to complication to mother in the form of maternal hypotension.
Agreed. So she might already have a low HB when you're taking her for cesarean because she's bled it inside, and then she may also have PPH. So what kind of blood are you going to arrange for her before you take her to the OT?
Yes.
That is a tricky one, because already if I'm planning, and definitely before if she's anemic also, before delivery definitely it is this one packed cell, and after delivery we'll have to give the plasma and fresh frozen plasma and other parts also.
Okay, so you have to plan for a massive transfusion protocol.
Yes, definitely.
You have to arrange blood and FFP and platelets if required. And Meanwhile, you can use cryoprecipitate, and they are given in the ratio of 1:1:1.
Okay. Thank you.
So that we have to keep in mind and keep ready. And what Dr. Jaideep Tank once said was that we are most of us private practitioners. So what happens is you get 4 bottles of blood and you don't use it, they'll kill you. So he said that when you're planning that surgery, have 1 blood in hand and keep a relative at the blood bank. That when we call, you come with the blood. So keep it grouping and cross-matching done, and then let a relative wait at the blood bank when you're doing it.
Definitely, because we are always short of such a precious resource. So it's always advisable to keep blood in reserve instead of getting it issued, because once issued, blood bank is not
They
going
will not take it back and it is wasted. So just grouping, cross-matching done, 1 bottle in hand, and immediately you will keep a relative there. So that is the way we are going to deal with this.
Yes.
And one more thing, because I've been working with MC Patel sir for a long time, that take consent for everything. Take consent of all the complications that might happen. Chances that, 1 placenta is gone, that baby may not survive, even when you're doing a cesarean. But still you need to do the cesarean to save the other baby, to save the mother. All this consent has to be very properly taken. So thank you, sir. Thanks a lot. You have 1 question left.
Okay.
So Dr. Dipanvita, back to you again. Dr. Jitendra sir and Dr. Vishal, are you there?
Yes, madam. I am there.
Okay.
Hello. Hello.
So, Mrs. B, 31 years old, DCDA twin at 33 weeks. She presents with fever, uterine tenderness, and foul-smelling vaginal discharge.
Yes.
Dr. Dipanvita, it's Dr. Vishal's question. You can pitch in if needed, okay?
Okay, ma'am. Sure, ma'am.
Dr. Vishal, please, sir.
Madam, it is the case. Might be the case of chorioamnionitis. As patient is having fever, foul smell, vaginal discharge, uterine tenderness is there. Along with, I will search for maternal and fetal tachycardia is there. And for lab investigations like WBC, CRP, and inflammatory markers.
Would you also do a blood culture, sir?
Yes, ma'am.
And do you want to send the discharge for any test? The discharge that she's having from
vaginal swab.
High vaginal
swab.
And a urine routine microscopy and culture, ma'am.
Routine. Okay. So, in twins,
protein survey, blood examination,
urine culture.
Sir already said CRP.
This WBC also.
Dr. Vishal, what are the specific reasons in a twin pregnancy that they might get chorioamnionitis?
Maybe PR.
What is one specific reason that happens? It's basically the stitch that people give.
Yeah.
Many of patients are getting stitches,
Tightening.
the McDonald's stitch, and if it's not exactly given, it is a major cause of chorioamnionitis, especially in twins. Now, if this patient is not treated, what will happen?
Patient can land up into the sepsis, fetal demise can be there.
And maternal demise?
Yeah, that's the same. Sepsis can be land up into the maternal demise.
Okay. So if a woman comes to you with fever, how are you going to differentiate between chorioamnionitis and any other cause of maternal fever? Could be viral.
Viral fever. Along with that, maybe.
No. How are you going to differentiate?
Chorioamnionitis and other maternal fever. For viral fever, viral or any infection, I have blood investigations, USG. And along with foul vaginal smell discharge is there, madam. That is their
and uterine tenderness.
And uterine tenderness is there.
MP should be ruled out, dengue should be ruled out.
Yeah.
The
So,
uterine
And
signs.
if
typhoid
a
also.
patient already has chorioamnionitis, would you plan an induction of labor or you want to do a cesarean?
Patient is 33 weeks. I will start
Yes.
with antibiotics. Steroid can be given. And wait for the blood culture,
Conservative treatment is
conservative treatment is initiated, and then
Means
Resuscitate
you would not
the
want to
plan.
do a cesarean with severe infection, right?
yeah.
If, ma'am, what is the presentation of twin one? That is important. How we would
Mode
deliver.
of delivery.
Means whatever the presentation, it's only 33 weeks. So what I'm asking you is if she has severe chorioamnionitis, acute, high-grade fever, tender uterus, are you going to put a knife or not?
No, not at all. It should not be.
Ma'am,
You want to first control the infection,
Control
right?
the infection.
Antibiotics, hydration, yeah, antibiotics, hydration, and monitor. And if the babies are stable, we can carry on. If the babies are showing good CTG, then we can just wait for the mother's
And actually
sepsis
allow
to be
the
controlled.
mother's infection to clear.
Clear, yes, ma'am. At least controlled. And then
What are the
plan.
neonatal complications associated with chorioamnionitis?
Sepsis, distress,
And then prematurity.
and prematurity. 33.
And prematurity ke apne complications,
Yes.
the whole list. So one woman has had chorioamnionitis in her pregnancy. She lost that pregnancy. Okay. She doesn't have a live child. Now she wants to know, she's pregnant again. She's come to you that will this time again will I get it? So what are you going to counsel her?
Risk can be there, but patient is
Means is it something that is repetitive? Is chorioamnionitis a repetitive disease?
It is not, ma'am.
It
But
is not,
if
ma'am.
it is not. But if she has harbored Group B streptococcus, we should actually look for GBS on an HVS at about 12 weeks, and then again nearer delivery. We can do urine cultures once every month, just to treat and pick up asymptomatic bacteriuria. These are two things that we could intervene, ma'am, and prevent further sad loss.
That is really good. Thank you. So now, Dr. Dipanvita, thank you, Dr. Vishal. You can
Thank you,
all
madam.
pitch in. Though I have written a name, it doesn't have to be just that person.
Yes, ma'am.
You know, so we have Mrs. N, 35 years old, BCDA twin at 34 weeks. Now, one twin has a velamentous cord insertion and one twin has a marginal cord. Okay, what are you going to do?
Both the babies are at risk of
She is 34
FGR.
weeks. She is 34 weeks.
Both
So
the babies
both
are
of them are going to have
FGR.
FGR.
Yes, ma'am.
Yes. So how are you going to monitor these babies?
So if they are at 34 weeks, they are FGR. If the Dopplers are normal, we can carry on. If the Dopplers at any stage, either the umbilical Doppler and finally DV Doppler, if is abnormal, we should deliver. And if the Dopplers are normal, we can carry on. So it's a Doppler that determines when we are going to end this pregnancy.
Okay. Now the first twin is cephalic and the second twin is also cephalic. Okay. Are you going to plan a normal delivery, a vaginal delivery?
How growth restricted are they,
be,
madam? That would
we can
matter.
plan.
No, you have carried them to 37 weeks. Okay. Are you going to try a normal delivery with a velamentous and a marginal? No.
No,
So
ma'am,
the key is the velamentous, where you are not going to try for that.
No. There can be cord accidents at any time. There can be placental accidents anytime. We cannot. Fetal distress in labor would be very common.
Okay. So what are the umbilical cord problems that can occur during pregnancy, during delivery? Compression. There can be compression, obliteration with the fetal head. It's a velamentous or a marginal, okay? So you need to locate the exact position. You have planned for a cesarean section. She's at 37 weeks. How will you take care that you are not going to injure the cord?
Sorry, my connection is very unstable. I couldn't hear you, ma'am. Hello? Ma'am, can you please repeat what you said?
See, this is it's question number 5. Read it.
Options for intrapartum fetal monitoring in dichorionic twin pregnancies with umbilical cord abnormalities. Intrapartum, if the patient is going for labor, you mean she wants to deliver vaginally.
But you will not allow that, right?
I would not be inclined to allow that, ma'am. But then if she absolutely wants to go for it, then continuous CTG in both the twins has to be continuously connected. And at any point there are any abnormalities, especially if it is a second twin that is showing abnormalities, we should strongly counsel that we might land up with
See,
bad
the
fetal distress.
velamentous means it is covering the os, right?
Yes, ma'am.
Then how are you going to allow a vaginal delivery?
No, we can't.
You
Sorry,
can't.
yeah.
So basically you just cannot. So you have, the most important part becomes the counseling. So you have to counsel that you cannot go ahead and have a vaginal delivery in this case. So now Dr. Radhika, Dr. Anshu.
Hello?
Yes.
Yes,
Hello. So we have Mrs. W, 30 years old, DCDA twins. There is FGR in one twin and the fetal weight is below 10th percentile.
Okay.
What could be the causes?
So, ma'am, in twin pregnancy, especially DCDA twins, most of the time it is placental insufficiency because of sharing of placenta preeclampsia. Coexisting preeclampsia
No,
is one of the causes.
there is no sharing of placenta in dichorionic. There is no sharing.
Placental insufficiency may be because of the associated preeclampsia with the twin pregnancy, limited size of the uterus, and most important thing that in twin pregnancy, because of the limited studies, we correlated with the normal growth curves. Up to 30 weeks, they follow the growth curves as the singleton pregnancy. After that, the growth in the twins already gets slowed. So there are strict criteria for that we have to label them the IUGR and we have to manage them according to IUGR. Otherwise, infection, discordant anomaly.
You have diagnosed that there is FGR. Okay?
Yeah.
So how are you going to monitor it in the 3rd trimester?
Yeah. So, ma'am, if it is an FGR, there are categories of FGR. In twin pregnancy, if the fetal weight is less than 10%, and otherwise the Doppler is normal, and there is no other associated factor, we can monitor it conservatively till it is more than 37 weeks. Otherwise, if there are two major criteria, abdominal circumference is less than 3%, or expected fetal weight management is expected fetal weight is less than 3%, or abdominal circumference is less than 3%, then we may have to do a Doppler and we may have to intervene. In your case, you're telling that it is less than 10%. So if the umbilical artery PI is not more than 95%, we can take it conservatively.
Well, you have to do Dopplers. There is no conservative. You have to do Dopplers because you have to.
Umbilical artery का PI Doppler से पता चलेगा ना मैम?
Umbilical and MCA, because you have to calculate the CPR. Okay,
Yeah,
the
definitely.
CPR has to be calculated. So umbilical and MCA and DV have to be done. There's no
Yes,
if and
sure.
but about it. What Dr.
Yeah.
Meenu said was that you have to do uterine artery, umbilical artery, ductus venosus, and middle cerebral artery. All
Definitely.
four have to be done every time.
Yes.
Okay, you're not waiting for that. And
Yeah,
she is
definitely.
already 36 weeks.
Yes.
So if you see that there is any kind of Doppler abnormality, what do you really want to do? You want to take out the baby?
Ma'am, in that depends upon the severity, what kind. If there is change in the ductus venosus or there is reversal of the flow in the umbilical artery, yes, we will, not may, we will terminate the pregnancy. Otherwise, if
Now,
there is just...
if you have growth restriction in these babies, what are the long-term consequences of growth restriction?
So long-term...
Those babies are born. You've given the mother 2 live babies. Okay. But what are the long-term consequences of IUGR?
Ma'am, depends the severity of the IUGR. If it is a mild IUGR, they usually do well and even better than the singleton pregnancies. Because in their case, it is most of the time, the umbilical artery flows remains normal for a long time and compromise is not that much. Various studies are there which tell that they do better if it is mild than singleton pregnancy. However, if it is too much severe, then yes, neonatal admissions are there, neonatal hypoglycemias, and neonatal infections are very common. And so much so that perinatal mortality is also higher in these babies.
Ma'am,
There is long-term neural... Yes, Dr. Meenu.
Yeah, so again, ma'am, since we're again talking about DV, I think what we again need to get here is there are 2 different spectrums of FGR that we are talking here. One is early onset FGR and one is late onset FGR. Even when you're talking about dichorionic twins. Now, in late onset IUGR, ductus venosus has no role. Now, if at 36 weeks you find that your CPR is becoming abnormal and you find that it is following the same trend even after 24 to 48 hours, we can decide to deliver this pregnancy between 36 to 37 weeks. There is no need to take an additional risk and try to prolong this pregnancy beyond 37 weeks. On the other hand, if this would have been an FGR with early onset FGR, then DV would have been a trigger for delivery and before 30 weeks of gestation. Now, after 30 weeks of gestation, if you have early onset IUGR with Doppler abnormalities, in DCDA, your trigger for delivery is going to be a reversal or an absent end diastolic flow, depending on which gestation you are going to see that particular Doppler abnormality. But in late onset FGR, essentially your DV and your umbilical artery will not have any role because in late onset IUGR, the amount of placental damage and is very less. And so, but the fetus is big enough. So even though the fetal hypoxia is small, it is actually going to go and affect your brainstem directly. So that is where the role of your NST and probably your deteriorating trend of CPR that will become more important and will act as a trigger for delivery for you, as opposed to early onset FGR, where you will take the trigger of delivery as DV or umbilical artery, depending on the gestational age.
Okay,
I
so
hope I'm clear on this. This is for early
Dr.
onset
Meenu.
IUGR.
Thanks a lot.
Yeah.
So there is a difference in early and late. What we are discussing here is late. And you will see these are the criteria. Estimated fetal weight less than 3rd centile, CPR less than 5 percentile, umbilical artery PI more than 95, MCA PI less than 5th, and uterine artery PI more than P59. You want to deliver her at 37 weeks. You don't want to carry more than that. So this is depending on what are the findings. So all 4 Dopplers are done all the time, but DV in late IUGR is not diagnostic. Early IUGR, it is diagnostic. And the trigger. Jagjit sir, back to you.
Ji ma'am, always there.
Yes, sir. So now we have a 37-year-old dichorionic twin pregnancy. She is 32 weeks. She presents with signs of coagulopathy, including petechia, ecchymosis, and prolonged bleeding from minor injuries.
Hmm.
So what could this be? What are the causes that could cause her to bleed like this?
At her gestational age, like it could
32
be
weeks. She's 32 weeks.
at her this just there could be underlying HELP syndrome, underlying placental abruption, preeclampsia, eclampsia is also included. Some signs of amniotic fluid embolism also present as coagulopathy. DIC may have occurred. So many
Sir,
a
common
time
cheez bolo na.
Thrombophilias.
Yes. So that is one thing. She might be on aspirin, she might be on heparin. Low molecular weight heparin तो कितना लगाते हैं
Yes,
IVF वाले?
she may be suffering from some liver disorder which have not been
Yes.
which have
And
remained
she might be a case of clotting disorder, where she will give a similar history throughout her life. Okay. So how are you going to diagnose this?
Obviously,
So that your
coagulopathy has to be diagnosed with laboratory test only.
Prothrombin time and partial
Actually, the International Society for Thrombosis and Hemostasis has come up with the scoring pattern for algorithm for diagnosis of overt DIC score kind of thing. So mainly the laboratory diagnosis of there is any known underlying disorder, plus if there are the number of platelets she is carrying, PT prolongation if it is more than in seconds, and fibrinogen levels. So all these are clubbed like, because they are scored for a pattern, and we can diagnose that. Specific test we can have screening for thrombophilias, evaluation of liver disorders, and
in pregnancy, we are worried about HELP syndrome. We are worried about ITP. Okay, and we are worried about DIC. So we are going to do tests to rule out these three major conditions. Now, if it comes that we have to deliver her, she's 32 weeks. So there are two factors. One is, what are you going to do to protect her pregnancy? Number two, what are you going to do so that she has a safe delivery? What are her blood levels that you want for her to deliver normally, to deliver safely?
The most important is once it's established that she is suffering from this condition, we must address the underlying cause.
Okay.
And secondly, the supportive
fresh blood
care, supportive care in like
Ma'am,
close unit.
where would you want to give platelets? Where do you want to give blood? When do you want to deliver the baby? You want to give steroids? You want to give Maxilf? You want to see her blood pressure and see her HELP syndrome condition?
If coagulopathy is
And we
severe and
hardly have
poses
any
a
time.
significant risk, then urgent delivery is required. So that is
urgent delivery में sir कितने platelet में आप operate करोगे? What is the minimum platelet count required where you will plan her surgery?
50,000 minimum, ma'am. 80,000 is better. 50,000 is minimum.
50,000 for normal delivery, 80,000 for cesarean.
Okay, consensus?
No, these are the guidelines, sir. FCCS
to be
guidelines.
transfused. Fresh blood to be given.
Okay. And most of the time, if it is due to HELP syndrome, once the baby is delivered, the patient will stabilize. If it is ITP, then you might to give her, what do we give in practice? Do any of you give vitamin K?
Yes, yes.
Yes, we do.
We are giving antenatally also.
Yes, so that is what now, जब हम बोलते हैं तो हम भूल जाते हैं.
We have to have, we have to have.
We all do it, but you know, the reason to bring these points out is कि जो सुन रहा है वो भी trigger हो. That you have to platelets only if it goes less than 50,000. You're not giving platelets before that. You're giving fresh blood. These are one of the rare conditions where you give fresh blood, or you can also give cryoprecipitate. Okay. Fresh frozen plasma भी देते हैं. नई fresh blood available होता है. You can give fresh frozen plasma. And you have to maintain platelets above 50,000. You give vitamin K. You treat the underlying cause, whether it is infection, whether it is liver disease, and explain everything to the patient. Prematurity of the babies has to be looked after, and with due counseling, you have to deliver the patient. And in spite of that, deliver the patient. You have to look at the obstetric indications.
Treating the cause is delivery as well, ma'am, because delivery may be
termination of the pregnancy.
So, any take-home messages from all of you? Any take-home messages? We've been really a long time.
So definitely, twin pregnancy needs more vigilant because antenatal care is much more meticulous and planned, more frequent visits, and more frequent for monochorionic than dichorionic. So that is the one message. Second is that timely action and can prevent many of the complication. And the third is that most of the time there are simple go-to things, but like just now mentioned, vitamin K, everybody is doing, and we usually forget to give those things.
I would like to say, ma'am.
Yes.
Frequent fetal surveillance is very important. Frequent fetal surveillance with ultrasound every either 15 days or in monochorionic, or either in 4 weekly in dichorionic DCDA. So monochorionic is more dangerous than dichorionic.
Ma'am, 2 weeks later we are going to do monochorionic. So I take one obstetric topic and one gynec. Next time we are doing post-menopausal HRT with intact uterus.
Yes.
With intact, madam?
With intact uterus, madam.
Okay.
Ma'am, one thing is clear that this was too in depth, for beginners, and yes, very much needed for every clinician. Such crisp guidelines are required. Most of the time we fumble on those things, that when to do this thing. So now it has become very clear. Both the presenter today, they were very good at it. Both the presentation were par excellence, and panel how you carried it with the vice person like us. It was beautifully presented, ma'am. Thank you.
Thank you, sir. Thank
Ma'am,
you.
Asha
Dr.
ma'am, I would also
Radhika?
like to thank you very much for the entire initiative, the hard work that has gone behind the scenes. And the two presenters were really excellent. Their content, their slide presented, it was too good, very good, ma'am. And you selected such excellent cases, very practical ones for the panel, and you conducted it so beautifully. And thanks for involving me. One take-home message about the twin pregnancy, I would say, is let us follow the guidelines that we have got, and let us try and prevent prematurity, because that has got such long-term consequence for the babies and the entire family. We should try till the last moment to carry on safely as long as we can, and follow the guidelines.
I agree.
Guide us. Yes.
Agreed. Radhika? You're muted. You're muted, dear.
As a private practitioner, I feel it should be a multi-speciality approach. Sometimes in smaller cities, it's just one doctor looking after the other. So we have to be in touch with our radiologists, our pediatrician, our neonatologists, so that we can have a cohort group, and the patient also has someone else to access to get information from. Because sometimes when we mention these complications, it itself becomes so scary for the patient that the patient may not come back to you ever again. कि यहाँ तो इतना सब कुछ बता दिया, होगा नहीं होगा. So I just feel, as a small town practitioner, I feel one should have a multi-targeted approach.
I totally agree, but there is one silver lining which nobody said today. that all these complications occur in only 30% cases.
I agree.
70% nothing happens. So,
I had a twin in my follow-up today, and when she came into the OPD, I had read for the past 2-3 days. So first I checked all her papers. What have I missed? Have I done something wrong or not? And then I said, fine, okay, everything is okay.
Z, Dr. Vishal, something from you, please.
Yes, madam. Thank you very much. बहुत ही elaborative discussion. बहुत से केसेस गूगली थे मैडम, लेकिन अच्छा है कि एक्चुअल क्लिनिकल प्रैक्टिस और यहाँ पे बोलने में बहुत फर्क है. थैंक यू फॉर इंटरेक्टिंग विद अस.
सर एक्चुअली सब चीज याद हो गया ना फिर से.
यस.
Yes.
We remembered everything, we revised everything, and we have experts to guide us.
Yeah.
And if by this everybody gets an interest in actually reading the ultrasound report, demanding that this is what I want in the report, then this session is successful, is what I feel. Because you know what to ask for from the radiologist. Otherwise, आपको पता ही नहीं होता है कि हम क्या पूछे उससे. And whatever they say is fine. So, you know, we need to know to ask.
Yes, ma'am.
Amla Devi, ma'am, you're still there. Would you like to say a few words before we end? Everybody is tired. Thank you, Dr. Alok, sir. Thank you, Dr. Meenu. We might have to call on you again.
Thank you, ma'am.
Thank you.
ma'am. Thank you so much.
Thank you so much, ma'am, for inviting. And the last thing I would want to say is that I thank my stars. I'm a radiologist. I'm not an obstetrician. Because you guys, you have to manage a lot of things. We have to manage just a small bit. And you people are superwomen and supermen, a few supermen. And thanks for inviting and having a wonderful discussion. Thank you all.
Thank you, sir. Thank you so much. Thank you, Mehul and Corona Remedies, for being our academic partners. Thank you, respected faculty. Thank you, all my delegates. Thank you so much for spending this evening with us. I hope you've learned as much as I have. Thank you.
Thank you, ma'am.
Thank you.
Mehul, you may end the session, please.
Yeah, sure.